Okay, so let's talk about the musculoskeletal system. We're going to talk about the function of the musculoskeletal system, some tests that we do to diagnose certain conditions of the musculoskeletal system, and then we'll go on and talk about some conditions. Okay. So, by the way, this is Dr. K, Dr. Kiragesian, or Dr. Greg, giving this voiceover, and we'll try and make sense of the chapters in the ATI. I'll focus on some topics more than others, okay? And I'll mention what is commonly done in real practice and when you're working compared to, no, this isn't that common, okay? So let's go on from here. Okay, so this slide is really just a reminder from pathophysiology about the function of the musculoskeletal system. So definitely one of the main functions is to support the body, right? So we have ligaments attaching to the bones that hold them all together. We have tendons attaching them that allow muscles to move. It's a huge reservoir of minerals, right? Calcium, phosphate. So the vast majority of our calcium is stored within the bone. Protection of vital organs. So we have a rib cage that protects our heart, protects the lungs. We have a vertebral column that protects the spinal cord. The skull protects the brain, and so on. Okay, so very important for protection of vital organs. That's not to say that every vital organ is protected. We do have some weak spots in our system. So, for example, the liver is tucked under the right ribs, the right lower ribs. The spleen is tucked under the left lower ribs. They're still prone to injury, but the ribs do provide some protection. Our abdomen is quite open in terms of very little protection to injuries directly to the abdomen. Okay, so there are some potential weak spots, but in general, the vital organs do have some protection from bones. Allow movement, right? So that's where through muscle contraction, voluntary movement occurs. Maintaining body temperature is through the blood supply that's circulating through the skin that can vasoconstrict to limit the release of heat, or vasodilate to allow for sweat and release of heat. Okay, so our body wants to maintain a very tight control of the body temperature. Okay. Promotes return of venous blood to the heart. Well, that would really be through movement, right? So when we're walking, for example, the contractions of muscles in our legs, in our calf, in our thighs, the muscles are continually contracting, and they're compressing those veins, which then allow the blood to move forward back to the heart. Okay. Reservoir of blood cells. So we have a huge reservoir of blood cells within our bone marrow, right? In fact, our circulating cells in the blood are made in the bone marrow. So your red blood cells, your white blood cells, your platelets are all made within the bone marrow. Okay, and I mentioned the reservoir for essential minerals such as calcium and phosphate. Okay, and we'll get into that a bit more. Okay, bone maintenance. So by now you will have heard that calcium in our diet, vitamin D in our diet, or through synthesis in the skin, um, maintains healthy bone. Okay, so we need a proper amount of calcium in our diet and a proper amount of vitamin D, which really takes about 20 to 30 minutes of sunshine, but we often get some vitamin D in our diet as well. Okay, thyroid hormone. So normal thyroid function or normal thyroid hormone levels maintains the bone. But I want you to remember that excessive thyroid hormone can lead to osteoporosis. Okay, so if someone, say, has Graves' disease and they have excessive thyroid hormone, or they're taking thyroid hormone because they had hypothyroidism, but they're taking too much, over the span of years, this thins the bones and leads to osteoporosis. Okay, cortisol. So if you have normal cortisol levels, no problem. But if you have excessive cortisol levels, whether it's from a condition such as Cushing's syndrome, where your adrenal glands make too much cortisol, or you're on exogenous cortisol, such as prednisone or dexamethasone, that tends to thin the bones. So excessive cortisol leads to osteoporosis. Okay, and that's a big issue if someone's having to take prednisone for long periods of time, say for severe asthma or severe Crohn's disease or ulcerative colitis, and they're on low dose cortisol or prednisone, it leads to osteoporosis. Okay, what else? Estrogen. Well, estrogen protects the bones. It maintains the bones, right? So not only does it enhance formation of bones, but it also inhibits bone resorption or bone breakdown. Okay, so premenopausal women have some protection from osteoporosis because they have high levels of circulating estrogen. Testosterone, again, it also stimulates bone and skeletal muscle growth. And so men don't tend to be as prone to osteoporosis as women because men tend to maintain testosterone levels through life. They can gradually drop as men get older, but not to the same extent as women and estrogen. So women at around the age of 50, plus or minus 2 years, so around menopause, they have lack of production of estrogen because the ovaries stop functioning. They stop producing estrogen. And in that 5 years after menopause, women can lose tremendous amounts of bone mass. Okay, and we'll talk about that a bit more. Okay, so remember, postmenopausal women, because of the lack of estrogen, are at significant risk of osteoporosis. If a woman has her ovaries removed for some disease, say they have severe endometriosis and it's covering the ovaries, and the ovaries need to be removed, well, they're at risk for osteoporosis because they no longer have circulating estrogen. And that's why younger women, say in their 30s or 40s, that have a procedure where either their ovaries have stopped functioning or they've been removed, need to go on to estrogen replacement. Otherwise, they'll have rapid loss of bone. Okay, so let's move on to some diagnostic procedures when we're talking about the musculoskeletal system. And there's a number of tests that we can do depending on what condition we're looking for. So if it's a fracture, okay, no problem. We'll do an x-ray. If we suspect somebody has weak muscles due to a muscle disease, we'll do a different test. So it just depends on what symptoms the patient presents with. That will determine what tests we'll perform. Okay, and we'll get into that now. Okay, so let's go through these, and then we'll go into them in a bit more detail. So X-rays, what are they good for? Well, they're good for looking at potential fractures. So somebody goes over on their ankle and we want to see if they have an ankle fracture. X-rays are fantastic for looking at potential sites of fracture. A CAT scan, again, say somebody has a fracture but it's very hard to see the three-dimensional part of the fracture. Say an elbow fracture, where there might be multiple areas of the fracture. We can do a CAT scan to look at that fracture and get even more in-depth detail about the fracture. Okay, so it just depends on whether we're happy with the x-ray and it's basically a simple fracture, and it's just a matter of going on and treating the fracture. MRI. So MRIs are fantastic for looking at joints. Okay, so somebody has a hip injury or a knee injury or ankle or shoulder, and we really want to look inside the joint, but not having to put a camera into the joint, just with an imaging test. MRI is the best. Okay, so it looks at the ligaments, it looks at the cartilage within the joint, it can see the tendons around the joint, it can see if something's torn within the joint. So MRIs are fantastic for looking at joints. The other part of the musculoskeletal system they're very good at looking at is the spinal canal. So if we think somebody has, say, a compressed disc, so an intervertebral disc that's compressing the spinal cord or compressing the nerves of the spinal canal, MRI is by far the best test to do to look at that. Okay. If we suspect somebody has, say, a C-spine injury, and we do an x-ray, we don't see any fracture, but we still think they have some kind of injury to the spinal cord, not the bones, of the neck, we could do an MRI, which shows us the spinal cord, it shows us the nerves leaving the spinal cord. So very, very sensitive test, okay? And remember, there's no radiation associated with an MRI. There's minor radiation associated with an x-ray, and there's significant x-ray, depending on what body part is being imaged, with a CAT scan, okay? What's an arthroscopy? Well, that is where we're going to put a camera into a joint, okay? And we're going to have a look in at the joint directly on the camera, and we can also do procedures while we're looking with the camera. So an example would be looking into a knee joint, seeing that there's a meniscus that's torn, and then through another port that's punctured into the knee, we can cut off the loose meniscus, or it can be tacked down. Okay, so that's arthroscopy. Nuclear scans we'll talk about. Another term for them is bone scans, and basically this is an injectable substance that will go to the bones, and then we can perform imaging tests to look at the entire all of the bones to see if there's any disease within the bones. So sometimes we'll do bone scans, say, for cancer. Or if we think there's a fracture, but we can't see it on x-ray, sometimes we'll do a bone scan, and the bone scan will light up the fractured area. Okay, we'll get back to that. So a DEXA scan, so a dual energy x-ray, DEXA is good enough, okay? So that's a bone density scan. So we call those bone density scans. What are they for? Osteoporosis. Okay, so a DEXA scan or a bone density scan. We don't usually get into that long word there, dual energy x-ray, absorptiometry, or okay. Electromyography and nerve conduction studies. Now we're looking at the muscles and the nerves that go to the muscles. So electromyography is basically putting an electrode into a muscle to see what's happening within the muscle. And nerve conduction studies is to see if the nerve that's left the spinal cord, say, is arriving properly with an impulse to the muscles. Okay, and we'll get into some of those as well. Okay, so here's an arthroscopy. Looks like it's being done on a, that could be a shoulder or a knee. Hard to tell from this image. But they both, we, there's arthroscopies done on either of those joints. So arthroscopies are super common, especially of the knee joint. Okay, so one of those puncture sites will have a camera that they're able to visualize on a screen, and another will have an instrument where they're able to remove loose parts within the joint, such as torn and damaged ligaments or torn meniscus, if we're talking about the knee joint. Okay, so it gives a direct view of someone who comes in with, say, joint swelling, ongoing pain. Crepitus is that kind of crunching sound when you move a joint. Or if someone has joint instability and they just can't walk on the joint anymore. Say it's the ankle or the knee and it's just unstable. They can't mobilize. Well, an arthroscopy can be can be used to look inside the joint. I'm going to tell you, MRIs are used much more for this because they give the same amount of information. The only difference is with an arthroscopy, you can actually do something while you're inside the joint. Okay, but MRIs are non-invasive, so there's an advantage to them. Okay, so you can see the indications there: repairing torn ligaments or meniscus, doing biopsies within the joint, and looking inside to see why someone has recurrent joint swelling or pain. Okay. What's the contraindication? Well, definitely if you have any kind of a skin infection on top of the joint, well, no one's going to puncture into a joint and go through a skin infection such as cellulitis. That definitely would need to be treated first. Otherwise, you could introduce bacteria into the joint, which is always serious. Okay, so whenever you get bacteria within a joint, which is called septic arthritis, that is a very serious condition because there should never be any bacteria within the joint. It's a completely sterile environment. Okay. Okay, so pre-procedure. So usually this is patient education about the procedure, what they're about to undergo. They may receive some sedatives and some analgesics if required for the procedure. Now, post-procedure, again, they might need analgesia after arthroscopy's been done. Typically, they're advised of protecting the joint and then RICE, right? So rest, ice, compression, elevation. Okay. Usually, it's for about 24 hours. Okay, after the procedure. Okay. So the big complication for this procedure is you need to report if you get a fever, if your joint looks red, if your joint becomes more tender, if it becomes more swollen and red, because of that risk of an infection in the joint. Okay, it's definitely a low risk with this procedure because they're really sterilizing the skin and making sure that there's no surface bacteria, but it's always possible. So the patient's going to receive a lot of advice on you need to report to us if there's any increased joint swelling, increased pain, fevers, or redness. Now, whenever a procedure is done on a limb, it's always a good idea to check the neurovascular status beyond where the procedure was done. So, for example, if this was an arm, well, we would check the color of the hand. We would check the pulses of the hand. We would check the sensation of the hand, okay, and the motor function of the muscles of the hand. So we want to see that the blood supply is going properly to the hand and the nerve supply is going properly all the way to the hand, okay, to make sure that nothing was injured during the procedure. Okay, let's move on here. Okay, so let's talk about a bone scan. So a bone scan is what I mentioned before. We're looking for something, for an abnormality within the bony system of the patient. Okay, so whether it's a fracture that we just can't see on x-rays, but we still suspect it, or we want to see if there's any metastatic cancer to the bones. A bone scan will light up, as you can see in the image here, if there's anything abnormal within the bone. Okay, so what happens is the patient will go to a hospital. They'll be injected with a radioactive isotope, and then they'll go away for 2 to 3 hours, and they'll return, and they'll receive this imaging test that basically will look at all the bones. Okay. Now, if it happens to be that we're just looking for a wrist fracture that we can't seem to find on X-ray, then they'll do a bone scan of the wrist. Okay, they won't do the whole skeletal system. Okay, but you can see in this image, they're basically getting the entire skeletal system. And often a patient that has cancer and we're looking for metastatic spread to the bones, they'll get a full bone scan of the entire skeletal system. Okay, so what does the patient receive in terms of advice pre-procedure? Well, they're going to be informed about the procedure for sure, and then they're going to be asked about allergies. Do they have any allergies to previous dyes or injections for imaging tests? Okay. Definitely they're going to be asked about pregnancy and lactation and renal disease, because that's where the radioisotope is going to be excreted. So someone with significant kidney disease, that would be one of the reasons to reconsider whether a bone scan or a nuclear scan should be done. Okay. Now, typically the bladder is emptied prior to the procedure so that all those pelvic bones that you're seeing in that image there are visualized properly. Okay. Post-procedure, well, the advice is to drink lots of fluids to excrete this radioisotope out through the urine, right? Now let's look at, we're gonna move on, but let's look at the indications here. So bone pain that we really don't know what's going on. Say we do an X-ray and we can't see much, and the person has persistent bone pain. Well, the bone scan can light up an area if there's really something within the bone. Okay. So let's look at the indications here. Arthritis. Well, arthritis is usually pretty well picked up by an X-ray. So often we wouldn't necessarily go for a bone scan with run-of-the-mill osteoarthritis. We can see that on X-ray. Okay. Osteomyelitis. So that doesn't always show up on X-ray early on. Now, as the infection with osteomyelitis progresses and the bacteria are chewing away more of the bone, then it starts to show up on X-ray. But that's a bit later on. Initially, when someone comes in with bone pain and it happens to be osteomyelitis, it doesn't always show up initially on X-ray. Okay. So a bone scan can pick up bone pain and we just don't know the cause, and it ends up being osteomyelitis. How about a fracture that we don't see anything on X-ray? Sometimes wrist fractures can do this, where we just can't see the fracture, and then we can move on and either do an MRI or we can do a bone scan. Osteoporosis, we're going to talk about another test coming up that's much more useful for osteoporosis to diagnose it, okay, which is going to be the DEXA scan. So we'll talk about that in a minute. Bone cancer. Absolutely. We do bone scans all the time for patients that we want to clear the bones of any cancer, or if they're complaining of bony areas and we're concerned that there's cancer in the bones, we'll do a bone scan. Okay. So there's the pre-procedural contraindications. So allergies to the radioisotope, pregnancy, significant renal disease. Okay. Post-procedure, just drinking lots of fluid, right? Remember, pre-procedure, empty the bladder so we can see the pelvic bones. Okay. What's a complication of this? Well, the kidney can take a bit of an injury, so an intrinsic renal injury because of the radioisotope that's been injected. Okay. Most of the time, the kidneys recover from this injury, and it's usually in patients that already have an injury to their kidneys, so they have renal disease, or they're dehydrated. So they've come in dehydrated, they didn't drink a lot of fluids, and the flow to the kidneys is reduced, so the isotope is more concentrated. But in general, most people tolerate this test just fine. Okay, the next test, a DEXA scan or a bone density test. This is really just for osteoporosis. Okay, so who is going to be getting DEXA scans? Well, it's going to be women more than men, for sure. And typically, it's you can have a baseline DEXA scan, to see someone's bone mass even before they're menopausal, say in their 40s, or we can screen for osteoporosis, typically after the age of 50. Okay, so patients typically go from this phase of normal bone density to what's called osteopenia, to then osteoporosis. So it's basically the degree of bone thinning, right? So this particular test, there's no injection, there's no radioisotope, there's just two beams that are used, typically at the hip, sometimes at the vertebral column, the vertebra. And what they do with these is they put it through a computer, and it tells us the density of the bone. Okay, and then you're given a score. Okay, and the score tells us whether you have normal bone density, osteopenia, meaning it's getting a bit thin, but it hasn't reached the osteoporosis stage, or yes, your bone is thin enough to be considered osteoporotic. Okay. So how do patients with osteoporosis typically present? Well, recurrent fractures. So they could have wrist fractures, vertebral fractures, hip fractures, basically fractures in any of those areas, or others. Okay, but wrist, vertebral, and hip are very common places to fracture with osteoporosis, and sometimes with a relatively minor injury. Okay, so they present with fractures, they present with loss of height because the vertebra of the spinal column are getting compressed slowly, so they're losing height, or they can present with bone pain, right, from injuries. Okay, so osteoporosis in itself doesn't give bone pain, but minor fractures can lead to bone pain. Okay, so typically this is not recommended if you're pregnant, just because there is a bit of X-ray associated with this, but there's no injection. Okay, so really think of this test for detecting the level of bone density to diagnose either osteopenia or osteoporosis. Okay, so what's electromyography? Well, that's just putting a needle into the muscles of concern and to see what happens within the muscle with a contraction. Okay, so it's really just studying the muscles, which makes sense, electromyography. What's a nerve conduction study? Well, this also involves attaching electrodes to the skin, and they detect the impulse, the nerve impulse, from one area of the nerve to another area of the nerve to see if there is normal conduction of the nerve impulse down the nerve. So a perfect example of utilizing a nerve conduction study is carpal tunnel syndrome. Okay, so we'll talk about this a bit more later, but it's where a nerve gets compressed at the wrist, so in the carpal tunnel of the wrist, and you get specific symptoms. So you typically get numbness of your thumb, your first digit or your first finger, your middle digit, and half of the fourth digit. Okay, so you get numbness there, and you get weakness of the hand. So you have difficulty holding things. People come in and say, you know what? Not only do I have numbness of my thumb and 2.5 digits, but I have problems holding cups now. I'm dropping things. And it's because the nerve that's being blocked is called the median nerve in the wrist, and it's creating weakness to the muscles of the hands. Okay, so really we're trying to diagnose a impingement of the nerve in the carpal tunnel with a nerve conduction test. Okay, so what are other indications? Well, basically any neurological disease, say of a peripheral nerve, or a muscle disease, well, that's where we would use electromyography, or a neuromuscular disease, so myasthenia gravis, or other diseases where we just want to see if the nerve impulse down the nerve is getting to the muscle normally and causing a contraction. Okay? So that's electromyography, that's for the muscle. Nerve conduction test, that is for looking at the conduction of the nerve impulse to the muscles. Okay. Okay, so in terms of pre-procedural checks, sure, asking the patient if they're on anticoagulants. We try hard not to poke people with needles if they're on anticoagulants. Muscle relaxants, because it's going to affect the contraction of the muscles. So if we're looking at doing electromyography, well, if you're on a muscle relaxant, it's not going to be as reliable. Okay. Skin infections, because we don't put needles through infected skin. Okay, so there's the reasons there. The last one, in terms of not putting creams or lotions on the day of the test, well, those areas are just going to be completely cleaned off before the electrodes go in. So, you know, to lubricate your skin or to put some kind of oil on your skin wouldn't be a good idea. Okay. Post-procedure, sometimes there is bruising at the site, right? Because it's punctured a little blood vessel and caused some bleeding under the skin. Reporting any areas that have become red, swollen, tender, because there's always a risk of developing an infection, right? So, and then the application of ice to prevent a collection of blood called a hematoma. So typically at the insertion sites, you can put ice packs on them just temporarily. Okay, so basically done this first chapter. So I'm just going to remind you, with CAT scans, yes, there's radiation. Sometimes we use injectable dyes with CAT scans. So that's going to require checking whether they have allergies to dyes. Kidney function test is required to see that they have normal BUN and creatinine. Okay. When it comes to an MRI, definitely we go and check that there's no metal. Patients usually have to fill out a questionnaire in terms of, do you have any metallic objects in your body? Have you ever had any surgeries? Have you ever had an eye injury? And sometimes, actually, before an MRI, we'll do an x-ray of someone's skull. If there's any potential that they may have had a bit of metal in their eye from a previous injury, we'll just x-ray the skull, and looking to make sure that there's no little bit of metal anywhere, because MRI is a very powerful magnet, And any metallic objects in the body, it won't necessarily pull out the metal. And, you know, in this really graphic um, scenario of where metal is being suddenly pulled out and ripping through the body, but small bits of metal can heat up within the body. And we want to know if someone has metal in their body that can heat up, okay? Especially if that little piece of metal is in the eye, because that can cause heating of the area and then injury to the eyeball, okay? So basically any type of metal, including, do you have a pacemaker, okay? Okay, so let's move on to some therapeutic procedures. But before then, I'm going to spend some time on this slide. There's not much on this slide. It just says arthroplasty and amputation. But I'm going to do the questions at the end of chapter 667 and just talk about some reasons why. Okay, so number one, a nurse is completing preoperative teaching for a client who is to undergo arthroplasty or arthroscopy, sorry. Which of the following statements should the nurse include? Avoid damage or moisture to the cast. That's incorrect because there's no cast. An arthroscopy is looking into a joint. There's no cast. Inspect your incision daily for indications of infection. Absolutely. After an arthroscopy, there's a risk of getting septic arthritis. So definitely checking the wound to make sure it's not red, swollen, and tender. Apply ice packs to the area for the first 24 hours? Sure. Because of you've had manipulation of a joint, you've had a camera go into the joint, maybe some parts of the joint have been cut out, such as meniscus. So sure, ice packs are totally reasonable for the first day. Keep your arm in a dependent position. So a dependent position just means hanging down, no elevation at all. That's not really correct, right? So when we're talking about rest, ice, compression, elevation, dependent position means you're not elevating it at all, okay? Perform isometric exercises, yes, right? So after a arthroscopy, the joint's going to get stiff if you don't move it as advised by the team that did the arthroscopy. So you're going to be given advice in terms of range of motion exercises. Okay, so the answer should be B, C, and E. Okay. Number two, nurse is planning care for a client who is post-operative following an arthroscopy of the knee. Which of the following actions should the nurse take? So assess color and temperature of the extremity. Absolutely. Okay. Remember, if you have any procedure to a part of the limb, you should assess the whole limb, so all the way to the toes or all the way down to the hand for color, which is basically telling you blood supply, and also temperature, which is also telling you blood supply. If you have poor blood supply, you're going to have a pale looking limb and you're going to have cold limb. Okay, so A is correct. B, apply warm compresses to the incision site. No, that's not true. You would typically apply cold compresses. C, place pillows under the extremity. Sure, you could elevate the leg to allow some drainage, so elevation is true. Administer analgesic medication, yes. Sometimes after an arthroscopy, there's pain. And assess pulse and sensation of the foot. Absolutely. So A and E are kind of saying the same thing, right? Assess pulse and sensation. So pulse, the blood supply, sensation, the nerve supply. Okay, so the answer should be A, C, D, and E. Number three, a nurse is assessing a client who is going to have a bone scan. Which of the following statements should the nurse include? Okay, you'll receive an injection of a radioactive isotope when the scanning procedure begins. Okay. You will receive an injection of a radioisotope 2 to 3 hours before the scan begins. okay? Because then you go away for a while and let it circulate through your bloodstream, okay? You will be inside a tube-like structure during the procedure. No, that's sounding like an MRI, okay? You're just having x-rays done after you come back from having received the injection, so that's not true. C, you will need to take radioactive precautions with your urine 24 hours after the procedure. No, that's not true. It's not needed after this procedure. It can be for other procedures where you receive radioactive medications, but for this one, not required at all. Okay. You will have to urinate just before the procedure. That's true, just to empty the bladder so that those pelvic bones can be seen with the bone scan. So the answer is D. Okay. Number 4, nurses educating clients at a health fair about a DEXA scan, so bone density scan. So I already know this has to be for osteoporosis. Which of the following information should the nurse include? Okay. A, the test requires the use of contrast material. No. Requires no contrast material, no injection. The hip and spine are the usual areas the device scans. True. That's where they look at the density. The scan detects osteoarthritis. That's not true. The scan detects osteoporosis and thinning of the bones. D, bone pain can indicate a need for a scan. Absolutely. Bone pain is one of the reasons why we do a bone scan, to see if anything lights up in the area of the pain. And E, females should have a baseline scan during their 40s. Yeah, a baseline bone density scan in your 40s gives you a reading of your bone health and how dense your bones are prior to menopause in women. So it's a good idea to have one. Okay, so the answer there should be B, D, and E. A nurse is planning, so number 5, a nurse is planning for a client who will undergo an EMG. Which of the following actions should the nurse include? Okay, assess for bruising. Who will undergo an action? Which of the following actions should the nurse include? Assess for bruising. Okay, so that can happen after you've been punctured with these needles, so sure. But it says who will undergo an EMG, so that's a bit confusing. Okay, A is a possible answer. Administer aspirin prior to the procedure. No, aspirin's a blood thinner, and you're going to puncture through the skin, so you wouldn't use aspirin. Determine whether the client takes a muscle relaxant. Good idea. If it's a muscle relaxant that someone's taken, it's going to affect muscle contractions, so it's going to affect the testing. Patients would be told usually, do not take anticoagulants, don't take aspirin, don't take muscle relaxants prior to this procedure. Instruct the client to flex muscles during needle insertion. Sure, because when you're contracting the muscle, there's going to be information that'll be provided through the electrode back to the computer. Okay, so that's true. Expect swelling, redness, and tenderness at the insertion sites? Definitely not. That would be a sign of potential infection developing, so you shouldn't expect that. So, I mean, I guess A is the answer. I don't really like it because those assess for bruising, that would be before, or sorry, after the needle's inserted, but sure. C is correct, and D is correct. Okay, good. We'll move on here. Okay, so let's talk about arthroplasty, which to me is really just a fancy term for joint replacement, or say a partial joint replacement. Okay, so surgical removal of a diseased joint. By far the most common reason would be the wear and tear arthritis, so osteoarthritis. Now, that's not to say that patients with, say, rheumatoid arthritis don't undergo joint replacements, because they certainly do. They have joint destruction. But the much more common one is osteoarthritis. Okay, it's just a more common arthritis as we get older. Which joints are typically replaced, most commonly, knee and hip. Okay, so it would be knee, hip, knee, hip, knee, hip, maybe an elbow, or maybe a shoulder. Knee, hip, knee, hip. Okay, so frequently it's those weight-bearing joints of the knee and the hip. Okay. Total joint arthroplasty means that all the components of a joint have been replaced. Okay. So if we're talking about a total knee arthroplasty, um, so a total knee replacement, we call it TKR, total knee replacement. That's the replacement of the distal femur. So on the top right there, distal femur, the tibial plate. So the top of the tibia has been replaced, and also the patella. Okay. So what about a total hip arthroplasty? Well, that's going to be a replacement of the femoral head. So you can see the ball on the lower right there. So the ball of the upper hip, and then the shaft of the replacement, or sorry, so the femoral head gets replaced, of course, and then the femoral neck and stem goes into the patient's upper femur shaft. Okay, so it's glued in to the upper femoral shaft. Now, with total hip replacement or arthroplasty, the acetabulum, the cup, is also replaced. Okay, so it's not just a new ball. It's the cup that's replaced too with a total hip arthroplasty. Okay. A unicondylar knee replacement is just when one side has osteoarthritis, say, and they replace just one side of the joint, not the whole joint. Okay. So that would be unicondylar, because in actual fact, your knee joint has a lateral part of it and a medial part of it in your knee joint. So if just one part is diseased, say the medial side, the inner side, well, they can do a unicondylar knee replacement. Okay. A hemiarthroplasty is typically referring to the hip where they've left the acetabulum intact, so they haven't put a new cup in, and they've replaced the femoral head, so a new head to the hip, and you get the femoral neck and stem. Okay, so that's a hemiarthroplasty. Okay, so you can see in the image here on the left side, there's been a total hip replacement. So you can see the acetabulum, which is the cup, and then the femoral head is within the acetabulum. Okay. So what are indications? Well, typically people with severe osteoarthritis or severe joint destruction from rheumatoid arthritis, they have a lot of pain, right? They can't go for walks anymore. They certainly can't go for runs. They have difficulty with stairs. They wake up with morning pain. So it's just to improve the quality of life and mobility, right? So osteoarthritis would definitely be the most common reason for getting a hip or knee replacement. Okay. What are the complications? Well, definitely you could get a hip dislocation. So where the ball of the joint, where the ball pops out of the acetabulum, that can occur for sure. And that needs to be put back in rather urgently. Okay. And it's not an easy procedure sometimes to put a prosthetic hip replacement back into the acetabulum when it's been displaced. Sometimes, or dislocated, sorry. Sometimes they have to go to the operating room for that. Infection. So any joint replacement, whether it's your hip, your knee, anywhere in the body, always have to think if someone comes in with fever, a red joint, a swollen joint, have to think of an infection. That is really serious. Okay, so an infected joint needs immediate attention with IV antibiotics, and often it needs to have a surgical washout, meaning they go into the joint and wash out the joint. Now with arthroplasty, with total hip replacements or total knee replacements, they often have to actually remove all the hardware. So all the surgery they did before has to come out because it's infected. And there's very poor blood supply to joints to begin with. And if it's an artificial joint, such as an arthroplasty, there's even less blood supply. So all that has to be removed. So it's a really big deal if someone gets an infection. Okay. Anemia can occur post-operatively. Why? Well, during the procedure, there's some blood loss, right? And some people will lose more blood than others. Neurovascular compromise. So you can imagine that the original hip is being cut out with a saw or a blade, and they're inserting the new replacement, the acetabulum and the metal femoral head and shaft. So there's nerves around there that go down the leg. There's blood vessels around there that go down the leg. So we do neurovascular checks of the foot, right? Does the foot have pulses? Is it nice and warm? Does it have good normal capillary refill? Okay, what about the nerves? Can they feel me touching their toes normally? Can they move the foot normally? So are the muscles working? Because the nerves innervate the muscles, right? So neurovascular checks. And then of course, after a replaced joint, DVTs. Okay, so whether it's the knee or the hip, there's a risk because of some immobility post-operatively, and also you're immobile because of the pain after the surgery, right? At risk for DVTs, deep vein thrombosis, right? So what do we do as prophylaxis for DVTs? So sometimes we'll administer medications to prevent a DVT post-operatively, such as heparin subcutaneously, or another type of heparin called low molecular weight heparin, such as enoxaparin, to prevent a DVT after surgery. Okay, so what else can we do on top of pharmaceuticals such as heparin subcutaneously, enoxaparin that can thin the blood a bit? Well, we can provide anti-embolic stockings. We can give. There's actually machines that provide sequential compression of the leg to keep the blood moving to prevent a DVT. Encouraging the patient to move to dorsiflex and plantar flex the foot, just moving the ankle up and down and up and down. That helps with flow of blood and prevents a DVT. Okay, and of course early ambulation, getting them up with physiotherapy and occupational therapy will definitely prevent a DVT from forming because the blood is starting to move with mobility. What about considerations before the procedure? Okay, so pre-procedural arthroplasty. So whether it's your knee or your hip, those are the most common for sure, for joints to be replaced. Any active infection. So if you have any kind of active infection, whether it's you have a cough or you've been diagnosed with a chest cold or pneumonia or a bladder infection, or that's not going to be very popular at the time of surgery, right? So they're going to hold off if someone has an infection because they definitely don't want this arthroplasty procedure to get infected or to get seeded with bacteria if someone has an infection. Okay. If there's arterial impairment to the extremity, so if someone has a significant blockage of an artery going to their leg, doing a procedure that's going to require a lot of healing, well, that would be a contraindication until they can assess the blood flow to the leg and to see if they can do anything about it, right? So blood supply is really important to a limb when there's procedures being done to it. Now, the first one I didn't mention, but I think I will, certain comorbidities. Well, definitely if someone has significant heart disease or significant COPD in their lungs, or poorly controlled hypertension, or their diabetes is terribly controlled right now. Well, those have to be taken care of prior to the surgery. Okay. Otherwise, the surgery is going to magnify those conditions, and patients can develop, they can aggravate their heart disease, they can make COPD much worse because they've just undergone a procedure. Okay. Okay, so the bottom left there, post-procedure care, that's pretty, I'm not going to spend too much time on that. Typically patients who've had a hip or a knee replacement, they're definitely going to need some pain control afterwards, so taking medications. They're going to need physiotherapy for weeks after to increase range of motion of the new joint. Monitoring for any signs of infection of the area, because as I mentioned, a septic joint is a really serious condition. Regular dressing changes is of course important, and monitoring for a DVT, so red, swollen, painful leg, typically on the side where the surgery's been done, but not necessarily. It could be on the other leg where it's become red, swollen, and tender. Monitoring for symptoms of a PE, so a piece of the clot has broken off of the DVT and traveled to the lungs. So sudden onset of shortness of breath, sudden onset of pleuritic chest pain, sudden onset of abnormal vital signs associated with chest pain and shortness of breath after a surgery would be a concern for a pulmonary embolus. Okay, and of course monitoring for bleeding at the site. Okay. What about some tests that are typically done prior to surgery? So these are routine tests, so a CBC, a urinalysis, electrolytes, kidney function tests, chest x-ray, and ECG. Remember, typically these patients are elderly in general because they're the ones who get osteoarthritis and joint destruction. So these are all screening tests to make sure that they don't have any abnormalities on their chest x-ray or their ECG, for example, or they're not anemic on their CBC. Older patients can sometimes surprise us with an underlying condition that hasn't been diagnosed yet. Okay. Under patient indications, so autologous blood donation. So some patients with surgical procedures can donate blood to themselves months before the procedure, and if required during the procedure, they can use their own blood. Okay. Infection risks, well, these are just ways of preventing infection. And taking normal medications with a sip of water, that's usually done the morning of, unless it's a medication that's going to interfere with the surgery, such as powerful anticoagulants or aspirin products, things like that where they don't want excessive bleeding at the time of surgery. Okay, so I'm not going to spend too much time on this slide at all. Some post-procedural considerations for knee and hip. I think these are covered really well in the book as well. So just in the interest of time, I'm going to move on from this slide. Okay, so let's look at these questions at the end of the chapter, and I think this is chapter 68. Let me just double check that. Yes, 68. So let's look at the question, and we'll just go through it together. If you want to skip forward, no problem. A nurse is reviewing the health record of a client who is to undergo total joint arthroplasty. Okay, so a total joint replacement. The nurse should recognize which of the following findings is a contraindication for this procedure. So age, no, never. We have 90-year-olds, 95-year-olds getting hip replacements. History of cancer, that's not a total contraindication. Because remember, if you fracture your hip and you have a history of cancer, well, you can't walk if you have a fractured hip. So you have to have it repaired in order to walk again, right? So a history of cancer is not going to preclude you from having a hip or knee replacement. Previous joint replacement, absolutely not. People have multiple joint replacements over time, so that's not a contraindication. Bronchitis 2 weeks ago, well, if someone has a chest cold and there's a potential for an infection, they're not going to be keen to do a joint replacement because of the risk of infection. Okay, so it's going to be D. Number 2, nurse is admitting a client to the orthopedic unit following a total knee arthroplasty. Which of the following actions by the nurse are appropriate? Check continuous passive motion device settings. Yeah, that would be a good idea following a total knee arthroplasty or total knee replacement. B, palpate dorsal pedal pulses for sure. So palpating the pulses at the ankle. That's the posterior tibial artery, and on top of the foot is the dorsalis pedis artery. Okay, so we definitely palpate that. Place a pillow behind the knee. If you place a pillow behind the knee is actually flexed, and a flexed knee is not a great position for a knee because the ligaments are in a more relaxed position and they have the ability to get stiff. Okay, they're not in a stretched position like they are when the knee is extended. Okay, so placing a pillow underneath the knee is not a great idea because of the flexion and causing a stiff knee. Elevate heels off bed. Well, in order to prevent an ulcer from occurring at the heel, elevating the heels off the bed is a good idea. Apply heat therapy to incision? No, that's not necessary. In fact, often we'll apply cold. Okay, so the answer would be A, B, and D. Number 3, a nurse is planning discharge teaching for a client who had total hip arthroplasty. Which of the following should the nurse include in the teaching? Okay, total hip arthroplasty, planning discharge teaching. Okay, clean the incision daily with soap and water. Okay, that's reasonable, just to keep it clean and reduce any chance of infection. Okay, turn the toes inward when sitting or lying. Okay, I don't think that's necessary. I don't really understand what that's asking. The client should externally rotate toes to prevent dislocation. Do they mean externally rotate the foot? Turn the toes inward when sitting or lying. Okay, I wouldn't choose that one because it doesn't make any sense to me. I think they're talking about the foot as opposed to the toes. Sit in a position, sit in a straight-backed armchair. Yes, that's a good idea. So straight-backed armchair keeps the hip at 90 degrees, and that's going to prevent a dislocation. Right? Bend at the waist when putting on socks. Well, bending at the waist. Bending at the waist. Let me just look at the answer here. The hip in a position greater than 90 degrees, which can cause dislocation. Okay. Use a raised toilet, sure. Using it decreases the chance of bending greater than 9 degrees. Yeah, okay, so that's reasonable. Okay. Not a big fan of that question. Okay, number 4. A nurse is assessing a client who is scheduled to undergo right knee arthroplasty. Okay. The nurse should expect which of the following findings? Skin reddened over the joint. I certainly hope not, because that would cancel the surgery if they thought it was infection. Pain when weight bearing. Absolutely, right? Because it's probably for osteoarthritis, so they're going to have pain with weight bearing. Joint crepitus is the crunching sound of an osteoarthritic knee or a damaged knee, so sure. Swelling of the affected knee, absolutely. So joint degeneration often leads to joint swelling. And limited range of motion of the knee or the joint, for sure. So those are all signs of joint damage, and the joint replacement is hopefully going to address all of those. Okay, so it's B, C, D, and E. Nurse is completing a preoperative teaching plan for a client who is scheduled to have a total hip arthroplasty. Which of the following should the nurse include in the teaching plan? Encourage complete autologous blood transfusion. Sure, yeah, that's a good idea. To have your own blood supply on hand for the surgery. Sit in a low reclining chair. So preoperative, no, that's going to make it very difficult to get up, right? So preoperative teaching plan, who's scheduled, and also not only that, after the surgery, that increases the risk of dislocating the knee, the hip. Okay. Instruct the client to roll onto the operative hip. No, that's going to cause pain, and it could potentially dislocate the hip. Use an abductor pillow when turning the client. So an abductor device is basically used to open up the leg a bit, and that's going to also prevent dislocation. Okay. Perform isometric exercises. Yes. So isometric exercises to increase or to maintain muscle strength, increase range of motion of the joint, and also prevent DVTs. Okay. All right. Sorry, but number 3, can't help you that much because I didn't really like the question. Turning the toes inwards didn't make much sense to me. Okay, so let's just talk about amputations briefly. So removal of an extremity, so upper or lower limb. It can be from trauma, so a crushed limb that's not viable, a severed limb that's not viable, severe thermal burns, peripheral vascular disease, so ischemia, say from atherosclerosis or from diabetes, where the blood supplies become so poor to the limb, typically the lower limb, that the patient is now getting ulcers and infections of the skin and possibly even the bone underneath. And the limb needs to be partially amputated. Okay? Malignancies, so cancers of the bone such as osteosarcoma, the patient needs to have an amputation to get rid of the cancer. Okay? Infection of the bone that just doesn't heal, so chronic osteomyelitis, sometimes requires an amputation because the antibiotics don't always completely get rid of bone infections. Okay, and then patients have to undergo a partial amputation. So the expected findings of someone who's requiring an amputation just depends on what the underlying issue is, right? So if it's from a crush injury, well, they're going to have very damaged tissue and fractures and likely poor blood supply to the limb. If it's from diabetes or atherosclerosis blocking an artery, well, they're going to have a pale appearing limb. They're going to have pain with walking, say, because they have a blocked artery, so they get claudication when they walk. They may have decreased sensation to the limb, especially in diabetics. They have a peripheral neuropathy, so they can often have decreased sensation. With a blocked artery, you're going to have reduced temperature because there's less blood flow getting to the extremity. The limb might look pale or cyanotic if there's a blocked artery, right? And if it's from severe atherosclerosis in the artery, sometimes the only option left is an amputation. They just can't open up the artery in all these areas that are diseased. Okay. The presence of ulcers, because there's poor blood flow to the limb, and ulcers can develop because of lack of blood supply to the skin. That can lead to infections such as cellulitis, osteomyelitis, all because of lack of blood flow. Okay. Okay, so how do we manage, even before looking at the material on this slide, how do we manage a traumatic amputation? Okay, so the big issue is if someone has an amputated arm or leg from a trauma, it's the bleeding, right? Those arteries are going to bleed and bleed and bleed until something is done. So sure, the first thing we can do is apply direct pressure with gauze to the area to try and stop the hemorrhaging. Next, we can try and elevate the limb. But if I'm going to tell you, if it's an arterial bleed, it's going to continue to bleed even once we've put it over the level of the heart. Okay. So often we're going to have to put a tourniquet on the limb because the artery is just pouring blood. Okay, and a tourniquet, whether it's a blood pressure cuff that we pump up really high, or a dedicated tourniquet that we just put on, and there's a device that you can twist and twist and twist to make the tourniquet super tight to block any more blood flow to the limb or the severed limb. Okay. What about the severed extremity? Well, we just put that in a dry gauze, okay, or some kind of clean cloth, and we place it in a bag, and then we submerge that bag in ice water. Okay, so we don't put the limb in the ice water. We put it in cloth, in its own bag, and then submerge it in the ice water. Okay. Okay, so what about interventions following an amputation? So a post-operative amputation. So it's going to come down to excessive bleeding, infection at the area, and pain, right? So what can we do for bleeding? Well, we can elevate the stump above the level of the heart. We can put direct pressure, and if that doesn't do it, we can put a tourniquet to stop the bleeding if it's severe enough, right? So these patients need monitoring of their vital signs. We need to assess the remaining part of the limb to make sure that there's good perfusion to the stump. So it looks nice and warm. It has good capillary refill. Okay. And of course, monitoring for infection, right? So is it red? Is it more and more painful? Does it have areas that aren't healing? Because infection of a stump can also lead to the underlying bone, right? And now you're dealing with osteomyelitis. Okay. So an amputation is done. Say someone has diabetes or atherosclerosis and a blocked artery. They have to go high enough up the limb, say we're talking about the leg, to make sure that there's good remaining blood supply to the stump, right? So there has to be a decision of whether it's going to be a below knee amputation or above knee amputation, and a lot of it depends on the blood supply, right? Because if you amputate too low down and the blood supply is poor, well, the wound's not going to heal, and it's going to be at risk for infection. Okay. Now, after amputation, the limb can be left in a dependent position to try and encourage more blood flow. If it's put in an elevated position, well, that's going to make the blood or the blood flow is going to be reduced when it's in an elevated position. Okay. Frequent dressing changes, administration of antibiotics, especially if the wound was left open, so the stump was left open because of potential for infection. Often they'll close the stump. Okay, so leaving a stump open usually means they want to allow drainage to go out because there's a potential for infection. Okay. Now, in terms of pain, so we spoke about bleeding, we spoke about infection. In terms of pain, sure, there's the pain of the procedure, so incisional pain, and of course, not only incisional, but also the muscles that have been cut through, the bone that's been removed. There's the surgical pain, and then there's the phantom limb pain. Okay, and I'm going to leave that part to you. It's well explained in the book. Now, I just noticed that there's a couple of drugs that they mentioned in this phantom limb section. So calcitonin is a hormone that can be administered. It's actually made by the thyroid gland. It can encourage calcium deposition in the bone. It can reduce phantom limb pain. Beta blockers, I'm going to tell you, I've never heard of beta blockers being used for phantom limb pain, but obviously they've been studied and have been shown to have some benefit. Anti-epileptics, so we use these all the time for ongoing pain syndromes. So you might recognize some of these: gabapentin and pregabalin. Pregabalin is Lyrica. And they're used for nerve type pain, right? So you might recognize these from someone with diabetic neuropathy that's on gabapentin or pregabalin. And they can also be used for phantom limb pain, okay? Antispasmodics such as baclofen and antidepressant medications, they can also help with the phantom limb pain. So the antispasmodic makes sense. Antidepressants also have effects on neurotransmitters, not just in the brain, and they can modulate the pain from phantom limb, so they're also used. Okay. I think that's it for the medication part. I'll leave the rest for you to take a look at. Okay. Okay, so this is what we were talking about on the slide before in terms of the post-surgical pain, so incisional pain. So opioid analgesics will definitely address that. The phantom limb pain, those opioid analgesics won't really address that kind of pain. And that's where we discussed calcitonin, briefly beta blockers, anti-epileptics are used for all kinds of chronic pain syndromes now. We mentioned a couple of those: pregabalin and gabapentin. Antispasmodics such as baclofen, and sometimes SSRIs are used, which are antidepressants. Okay. There's also non-medication approaches, so therapies such as massage, heat, electrical stimulation, TENS, relaxation therapy. They can all be effective. Okay. So a closed amputation is where the amputation has occurred, and then they wrap the remaining skin flap and completely close over the remaining limb, right? An open amputation is where there's infection occurring. They definitely don't want to close over the remaining stump. because they'll trap in the infection. So it's left open. Okay. Now they can go back weeks to months later and have a revision and have it closed. There's quite a number of different professions involved in this, so you're definitely going to have a someone who deals with orthotics to fit the prosthetic properly. Physiotherapy is going to be involved for sure. A psychologist may be involved, adjusting to the fact that the patient's lost a limb. And sometimes even a social worker may need to be involved, right? For financial issues, for support, and ongoing advice where they can find that support. Okay. Okay. Again, in the interest of time, I'm going to keep moving. Amputation complications. They're covered in the book a bit. So the psychological well-being, so allowing for grief, due to the lost limb. Hypovolemia, that would be more of an acute post-surgical issue. Loss of blood. Infection is always a risk, especially post-surgical, once the wound's completely healed and closed. Flexion contractures can occur, and I'll leave just the advice on how to avoid flexion contractures for you to look at. Okay, so let's just do these questions at the back of chapter 69 together, sorry. So a nurse is presenting information to a group of clients at a health fair about measures to reduce the risk of amputation. Which of the following should the nurse provide? Encourage clients to stop smoking. Absolutely. So smoking leads to atherosclerosis, which causes peripheral vascular disease and reduced blood supply to a limb, in particular the leg, and that can lead to amputation. Encourage clients who have diabetes to maintain blood glucose within the expected reference range. Yeah, that's a good idea to have really good control of serum glucose, because we know that if you have tight control of your serum glucose when you're a diabetic, it reduces the chance of developing complications of diabetes, such as atherosclerosis, peripheral neuropathy, renal failure, blindness, cardiovascular disease. So B would be true. Instruct clients to unplug electrical equipment when performing repairs. Well, I guess that would be true in order to prevent a serious electrical injury to the leg or to the limb, which may require amputation. Okay. Encourage clients who have vascular disease to maintain good foot care, for sure. If you have vascular disease to a limb, that means you have poor blood supply to the limb. If you have poor blood supply to the limb and you get an ulcer or an infection of the limb, the body's going to have a really hard time healing it, because the body heals through the blood. So that can turn into a raging infection that may require amputation. So good foot care is really important. Okay, so A is correct, B is correct, C is correct, D is correct. Advise clients to wait 2 hours after taking pain medication before driving. I don't really know how that pertains to this. Yeah, not really clear on that one. So A, B, C, D. Advise clients to wait 2 hours after taking pain medication before driving. There's many people out there that take medication, pain medication when driving, but usually what we advise is take the medication to see how it affects you first. So whether it's a pain medication or a sedative for anxiety or for insomnia, take the medication to see how it affects you prior to driving. Okay. Number 2, a nurse is assessing a client who has arteriosclerosis, so atherosclerosis and is scheduled for a possible right lower extremity amputation. Which of the following are expected findings in the affected extremity? Okay, so what will a limb look like before the amputation? So, and it's already saying that they have atherosclerosis, so they have a blocked artery to the limb. So I'm expecting changes in the limb due to lack of blood supply. So skin is cool to touch from mid-calf to toes. Absolutely. Your skin has less blood supply, so it's going to be cool to touch. B, increased sensitivity to fine touch. No, your nerves shouldn't be more sensitive. In actual fact, as you have more and more blockage of arteries to the leg, you're going to have less sensation, right? Next one, palpable pounding pedal pulses. Well, that's a really good sign. That means you have fantastic pulses when we check them at the ankle and the foot. So that's not correct. Lack of hair on lower leg. Yes. So your hair follicles are dependent on blood supply. So when you have poor blood supply to your leg, you have thin, shiny skin, less hair because it's died off, right? It's been ischemic because of the atherosclerosis. Blackened areas on several toes, absolutely. So that's ischemia, right? And that's death of tissue that can lead to gangrene, right? So the blackened areas are just dead tissue from the blocked artery. Okay, so the answer would be A, C, D, and E. Okay, so let's go on here. Number 3, a nurse is caring for a client following a below elbow amputation. Which of the following actions should the nurse take? Encourage dependent positioning of the residual limb. Yes, so we spoke about this before. So encouraging a dependent position is going to allow blood to flow to the dependent area because you're actually having gravity work on your side, right? So more blood, more healing. Inspect for presence and amount of drainage. Sure. Okay, so you always want to check to make sure that there's no signs of infection whenever there's a wound. Implement shrinkage intervention of the residual limb. Yeah, so preparing a residual limb would include this so that it can then be fitted for a prosthetic. So that would be true. Wrap the residual limb in a circular manner using gauze. I don't think that would be a good idea. So wrapping the residual limb in a circular manner using gauze. So that could, if the limb were to swell, that wouldn't allow for expansion. So that could cause reduced blood supply by doing that. That would be a good idea. Assess for feelings of body image changes, for sure. Right? This person's just had an amputation. So there's all kinds of emotional changes that can occur following amputation. So A, B, C, and E. So just leave D out. A nurse is caring for a client who had an above knee amputation. Client reports a sharp stabbing type of phantom pain. Which of the following actions should the nurse take? Remove the initial pressure dressing. I don't think that's a good idea. Taking the pressure dressing out could lead to a whole new problem, which would be bleeding, right? So I don't think that would be a good idea. Encourage the use of cold therapy. I don't think cold therapy is a therapy for this. It's often heat that's used. Question whether the pain is real. We don't usually question whether someone's pain is real or not. It's their pain. So don't really see ourselves as detectives of someone's pain, right? We tend to take patients and their degree of pain as real, so that wouldn't be appropriate. Administer an anti-epileptic medication. So anti-epileptics also are able to modulate pain, and that's why they're used in, say, chronic low back pain, diabetic neuropathy, phantom limb pain. So we're in the group of medications such as gabapentin, pregabalin. Okay, so that would be the answer there. Okay, 5, a nurse is preparing a plan of care to prevent a client from developing flexion contractures following a below-knee amputation 24 hours ago. Which of the following actions should the nurse include? Limit any type of exercise to the residual limb for the first 24 hours after surgery. No, that wouldn't be a good idea. Limiting movement is rarely a good idea. B, position the client prone several times a day. Yes, that's true. You can have the patient prone to try and prevent flexion contractures. Wrap the residual limb in a figure of 8 pattern. Nope, that's not going to help prevent flexion contractions. Encourage sitting in a chair during the day. While sitting in a chair is not going to prevent flexion contractures, right? So it's more of an extension position that you would want to be in. So no, sitting in a chair all day is not going to prevent that. So 5, the answer is B there. Position the client prone several times daily. Okay, so we're going to move on to osteoporosis on the next slide. But let's just look at these different postures. So whenever we're doing a physical assessment of the musculoskeletal system, it's always important to see someone's posture, right? So kyphosis is that rounded thoracic spine, and it's from compression fractures of the thoracic vertebra, right? Typically from osteoporosis. And you get that humpback appearance because the compression fractures are causing not only a reduction in height of the person, but they're causing that rounded appearance of the back. That's called kyphosis. Okay, so thoracic kyphosis. Lordosis is that curvature at the lower part, and it's normal to have some lordosis of your lower back. Okay, that person in the middle has a good posture. Okay, some people can have really significant lordosis, but it's normal to have some lordosis in the lower back. And lastly, scoliosis, where the spine is not perfectly straight. And looking at this image on the right, C, you can see that there's curvature of the back, so there's lateral curvature of the back, and we call that scoliosis. And often, if we're not really sure if someone has scoliosis, we'll just ask them to bend forward. And that really shows the curvature of the spine. So sometimes when they're standing straight, it's hard to tell. This one's not. But then when they lean forward to touch their toes, it really stands out. Okay, so looking at the posture, seeing how they walk really helps. So if they have a knee issue or a hip issue or a back issue, looking at their gait will definitely help. Range of motion of all the joints, so the hip joint, the knee joint, the ankle, okay. Muscle strength and the size of the muscle groups. So just looking at, say, their thighs, do they have any atrophy of the muscles? Do they have any atrophy of the calf muscles? So just getting, and you always have another leg to compare to, or usually you do, right? So we're looking for symmetry. So range of motion, do they have equal range of motion on each side? Do they have equal muscle size on each side of their limbs? Neurovascular status, of course, is always important. Checking the pulses of the lower leg, checking for sensation and muscular strength. So that's the neurovascular status. Okay. Okay, so let's talk about osteoporosis, which really is thinning of bones and low density bones, right? So they just don't have as much calcium and phosphate um, in the bony structure anymore. Okay, and that results in a low bone density. So typically, our bone mass starts to decline in our 30s. Okay, so the osteoclasts that break down the bone exceed the production of bone, which is done by the osteoblasts. So over time, the bone is just getting thinner and thinner and thinner. Okay, and that's why it's important to try and prevent osteoporosis starting at an earlier age, in your 30s and 40s. Because as you'll see, the treatment once you have osteoporosis is really just treatment. It doesn't reverse the bones back to normal. Okay? There's definitely risk factors for osteoporosis. One of the prime ones, or one of the main ones, is postmenopausal women because of that lack of estrogen. Okay? So in terms of health promotion, maintaining or consuming proper amounts of calcium and vitamin D is really important younger in adulthood to maintain bone density. Now, if you look, there's not a lot of foods that are high in vitamin D. Now, milk is fortified, so that tends to have a lot of vitamin D. So cheeses, milk, dairy products. There's cereals that have vitamin D added to it. Some fish, eggs, they all have vitamin D. Okay, but there's not a lot. And don't forget, you get vitamin D from sun exposure to your skin as well. The skin synthesizes an inactive form of vitamin D, which is then activated in the kidneys. Foods rich in calcium are important. So again, milk products, leafy vegetables, orange juice, they often add calcium to it, and also cereals. Okay. So remember to spend some time outside, and that is why often in colder climates, northern climates, osteoporosis is even more common because a good segment of the population is vitamin D deficient. And without vitamin D, you can't absorb calcium from the gastrointestinal tract. So weight-bearing exercises, really important to prevent osteoporosis, right? So if you're using your bones, they don't tend to break down as quickly. So walking, some degree of weightlifting, but even just simply walking maintains proper bone health. So when we're doing an assessment on someone with osteoporosis, meaning low bone density. So remember, osteopenia means on bone density test, you have a thinning of the bones, but it's not quite enough to call it osteoporosis. So we'll call it osteopenia. Okay. So what are some findings of osteoporosis? Well, reduced height. Okay, that's from the vertebral compression fractures that occur, and from kyphosis. People lose their original height. Back pain, right? So acute back pain. Some people with severe osteoporosis, just lifting up, there's bending over and getting back up can lead to a compression fracture because the bones are so incredibly thin. A history of fractures, in particular compression fractures of the vertebral spine, wrist fractures, hip fractures, those are all indicators that this person might have osteoporosis. Kyphosis we spoke about, that humpback or that rounding of the thoracic spine. And then of course pain upon palpation of the spine would be an indication that there's something going on with the bones. Okay. On the right, just giving you an image of what normal bone mineralization would look like. And then osteopenia is just thinning of the bone, but not osteoporosis yet. And then osteoporosis, you can see that there's definite loss of calcium phosphate and then severe osteoporosis. Look at the huge gaps. So there's much more marrow, but the calcium phosphate part of the bone is vastly diminished. Okay, so let's just look at diagnostics first, and then we'll look at the fracture risk tool. So what about labs? So just because you have osteoporosis doesn't mean you're going to have an abnormal calcium level in your blood. Now, you might be vitamin D deficient because you're not getting proper amounts of vitamin D, or you're not in sunlight very often, so you're not producing vitamin D. But calcium and phosphorus levels don't really translate into the person having osteoporosis. Alkaline phosphatase is just an enzyme that's made in the liver, and also it's made in the bones. So if you have an elevated alkaline phosphatase, you can have it in the setting of liver failure, or you can have it in the setting of some kind of bony disease. Okay? The imaging is the most important. Now, x-rays are not very sensitive for osteoporosis. By the time we're seeing osteoporosis on an x-ray, you have significant thinning of your bones. Okay, so it's not we don't use that as a screening tool for osteoporosis. We use a bone density scan or a DEXA scan. And that really shows how dense or how thin or osteoporotic the bones really are. Now, so the DEXA scan can be used, and now what's being used is ultrasound as well. So an ultrasound can be applied to the heel or the tibia or the patella, and that can also give us an indication of how dense the bones are. Okay, so a DEXA scan, and now a quantitative ultrasound can also be used. Okay, CAT scans aren't used typically for bone density. There's quite a bit of radiation to it, and we don't really follow osteoporosis with CAT scans very often. Okay, so let's look at the fracture risk. Okay, and these are important to know because osteoporosis is a common condition. Okay, so the first risk is age. So definitely as we age, remember, we're losing more bone than we're producing after the age of 30. So age is definitely a risk factor for osteoporosis. Gender, much higher in females, especially postmenopausal females, right? That's where women lose a lot of density of their bones because of the lack of estrogen. Someone who has a low body mass index, so they already have a very light frame, especially a female with a light frame. Okay. History of previous fractures is in itself a risk factor for having osteoporosis. A parent, so typically a mother with a history of hip fractures or a history of osteoporosis. A smoker. So what does smoking do? It reduces oxygenation of bones, and just like other parts of the body as well, and that leads to poor bone development and lower density bones. So smokers are at risk for osteoporosis. Current use of corticosteroids, definitely. If you're on corticosteroids long term, you really need to be on calcium and vitamin D, and even some of the medications we use for osteoporosis to try and prevent osteoporosis from developing. So taking corticosteroids is definitely a risk factor for osteoporosis. History of rheumatoid arthritis. So that would be a risk factor. I would say the biggest risk factor with that history is that you're typically taking corticosteroids sometimes to treat the underlying rheumatoid arthritis. By the way, coffee intake is a risk factor for osteoporosis. Okay. What else? Alcohol. So alcohol intake can also impair bone development and lead to osteoporosis. What about secondary causes? So say you have type 1 diabetes, that's a risk factor for osteoporosis. Osteogenesis imperfecta is a bone condition where the bones don't form normally, so that's definitely a risk factor. I mentioned the fact that if you have hyperthyroidism or you're taking levothyroxine for a low thyroid condition, but you're taking too much of it, over time, that's going to thin your bones. So don't forget, hyperthyroidism or taking too much thyroid hormone can lead to osteoporosis. Premature menopause, or you had your ovaries removed because of some condition, well, that can, now you're not making estrogen, that can lead to osteoporosis, okay? Chronic malnutrition or malabsorption syndromes such as celiac disease, lactose intolerance, any of those can also lead to poor absorption of calcium that can then lead to osteoporosis. Chronic liver disease, well, vitamin D in being activated from the skin, it goes through the liver and then the kidney in its activation process. So if you have chronic liver disease, you're not actually processing your vitamin D properly. So that's going to lead to poor absorption of calcium. Okay. Another one is high levels of intake of phosphorus. Okay. It tends to leach the bones. So very high consumption of carbonated beverages can also lead to osteoporosis. Okay, and the one that's not listed here is sedentary lifestyle. So if you're not using your bones, if you're not providing weight-bearing activities and exercises, the bones won't stay strong. Okay, so let's look at some interventions for osteoporosis. And actually, a lot of these are osteoporosis preventions as well, right? Even if you don't have the condition. So maintaining calcium and vitamin D in your diet, very important, right? Because calcium is what makes up the matrix of the bone, calcium phosphate. Limiting caffeine, yes, it leads to osteoporosis. Alcohol, another factor leading to osteoporosis, and carbonated drinks. So high consumption of carbonated drinks, all should be limited. The need for proper intake of proteins, magnesium. Vitamin K, you would think of, well, vitamin K is to make clotting factors so that your blood clots normally. But it's also needed for bone health, okay? It's needed for active osteoblast activity. So yes, I would think of vitamin K as really important for clotting factors when you're on warfarin. Say sometimes we have to reverse warfarin with vitamin K or Coumadin, but it's also for bone health. Okay, being out in the sun for 20 to 30 minutes is enough for your skin to synthesize cholecalciferol, okay, inactive vitamin D that gets fully activated in the kidneys. Encouraging weight-bearing activities and exercises for sure, right? If you don't use your bones, they get thinner and thinner and thinner, okay, leading to osteoporosis. The next ones are really just to avoid falling, right? So safety equipment in the house, such as bars for elderly people, avoiding slippery surfaces, clearing walkways. That's really just to avoid the fall. Because when someone with osteoporosis falls, typically something's going to break, right? The hip, the wrist, sometimes the femur, compression fractures of the back. Medications, we'll talk about some of them. So some of them that decrease bone resorption. Resorption means breakdown. So stopping bone breakdown. Stimulating bone formation is another group. Estrogen replacement. Estrogen definitely protects bone health, and that's why I'm gonna remind you over and over again. Postmenopausal women lose their estrogen because of lack of ovarian function. Estrogen deficiency leads to osteoporosis, especially in the first 5 years after menopause. Okay. Other medications, well, we mentioned calcium supplements and vitamin D supplements. Okay, and on the right, just some images. What has vitamin D in it? So mentioned eggs, cheese, some fish stew. So just take a look at what has vitamin D. What's rich in calcium? Well, the lower slide. Okay, so just have an idea of some common foods that are rich in calcium and rich in vitamin D. Okay, so just on this slide, if you want to skip it, no problem. I'm just going to do the questions at the back of the ATI book. So this is chapter 70. A nurse is admitting an adult client who has suspected osteoporosis. Which of the following findings are risk factors for osteoporosis? So history of consuming 1 glass of wine a day. That's not really a risk factor. So heavy alcohol consumption is a risk factor. 1 glass of wine a day would not be considered heavy alcohol consumption. It's kind of a sneaky answer though, because I mean, alcohol is a risk factor, but 1 glass isn't enough. Loss of height of 2 inches. It is it's an indication that there's osteoporosis. So is it a risk factor? Okay, I guess it is a risk factor, but it's also an indication the person already has osteoporosis, right? A body mass index of 18, so that's low, right? So that's basically just under normal. That means the person has a light frame, and that's a risk factor for osteoporosis, since they're starting with an overall light frame as they go into their 40s, 50s, and 60s, so they're at risk for osteoporosis. Okay. Kyphotic curvature of the upper thoracic spine. Well, that's an indication that they already have compression fractures of the thoracic spine. So it's telling us that, yep, there's osteoporosis here already. So is it a risk factor for developing it? It's a risk factor basically telling us that there's osteoporosis already. History of lactose intolerance, that's a malabsorption issue in the small intestine. So you can have malabsorption of calcium, minerals, vitamin D. So that would be a risk factor for sure. Okay, so the answer would be B, C, D, and E. Okay, A is not the answer only because they said 1 glass of wine. A nurse is providing care for a client who had a vertebroblasty of the thoracic spine. Which of the following actions should the nurse take? Apply heat to the puncture site. I'm going to tell you, usually you don't apply heat to a puncture site post-surgical. It's usually you're going to apply something cold, if anything, because of potential swelling. So now, what's a vertebroplasty? Well, it's where they've injected this hardening compound, almost like a cement, that is supposed to stabilize the compression fracture. I'm going to tell you, I don't think it's often done, but that's the procedure, done through an injection. So place the client in a supine position. Yes, you would do that and ask them not to move for an hour or two to let the cement, let this compound harden. So B would be the answer. C, turn the client every 1 hour. No, that's going to move the spine potentially. Ambulate the client within the first hour post-procedure. No. Again, because you're going to potentially disrupt the cement that's been injected. A nurse is providing dietary teaching, this is number 3, about calcium-rich foods to a client who has osteoporosis. Which of the following foods should the nurse include in the instruction? So white bread really doesn't have any calcium. Apples, no calcium. And brown rice wouldn't have much either. Definitely kale would have the highest concentration of calcium amongst these for sure. Okay, next question. A nurse is performing health screenings at a health fair. Which of the following clients have a risk factor for osteoporosis? 40-year-old who has been taking prednisone for 4 months. Okay. A 30-year-old client who jogs 3 miles daily. Definitely not. So, by the way, yes, right? Anyone who's taking prednisone for 4 months is at risk for osteoporosis, right? So, any corticosteroid that someone's taking for a prolonged period of time is going to thin the bones. So A is correct. B is not correct. That person's not at risk for osteoporosis. A 45-year-old client who takes phenytoin for seizures. So phenytoin is an anti-seizure medication, but one of its effects is that it can thin bones, mainly due to its effect on decreasing calcium absorption and also affecting calcium metabolism. So that's just something you're going to have to remember about phenytoin. Okay, so that one's correct. A 65-year-old who has a sedentary lifestyle, absolutely. Sedentary lifestyle, inactivity, the bones are going to thin because they're not being used, right? So that one's correct. A 7-year-old client who has smoked for 50 years. Smoking is definitely a risk factor for osteoporosis because you're impacting oxygenation of tissues, including the bones, right? So the bones are getting less nutrients, basically, less oxygen. Okay, so the answer here would be A, C, D, and E. Okay, last question here. Nurse is planning discharge teaching on home safety for an adult client who has osteoporosis. Which of the following information should the nurse include in the teaching? Remove throw rugs in walkways. Good idea, right? So adult client with osteoporosis, you don't want them to fall. Something's going to break. So remove throw rugs in walkways. It's just a perfect, throw rugs are just perfect to trip on, right? The tip of your foot just catches the throw rug and down you go. Use prescribed assistive devices, absolutely, to minimize any falls, right? Remove clutter from the environment. Okay, that makes sense because clutter you can trip on, right? So removing that is always a good idea. Okay, wear soft bottom shoes. Okay, I don't know why that would be information the nurse should provide in teaching because soft bottom shoes are totally fine to wear. Okay, it's not going to impact osteoporosis. So I don't think that one should be correct. Maintain lighting of doorway areas. Sure. Yep. Maintain lighting so that they see where they're walking and they don't fall. Okay, so once you know the information, any question that's thrown at you, you can work yourself through it because that's basically what NCLEX is going to be, right? Okay, I know the information, so whatever question they throw at me, I'm going to be able to figure it out. Okay, well, let's go on. Okay, so let's move on to musculoskeletal trauma. We're going to cover fractures, some common types of fractures. We're going to discuss complications of fractures and different techniques of repairing fractures. So some of this will be topics that were started from last semester and just more detail this semester. Okay, so let's start this. Okay, so contusions, strains, and sprains. So a contusion, just a fancy word for a bruise. That's it. Okay, so basically it's a soft tissue injury where the blood vessels have broken under the tissue, typically in the muscle or the skin, and they've just bled into the tissue. That's a contusion. Or if you want to say an ecchymosis, even fancier, but basically it's just bruising. Okay, what's a sprain? So a sprain is typically an injury to ligaments. Okay, so it's typically a ligament that is stabilizing a joint, say your ankle or your knee, and you've sprained it. You've stretched the ligament. And what do ligaments do? They attach bone to bone, right? What do tendons do? They attach muscles to bone, right? There's a tendon in between them. Okay, so a sprain we typically reserve for ligamentous injuries. Okay, and that's why it's saying caused by a twisting or hyperextension of a joint. Okay, that's where the ligaments are kind of stabilizing the joint. What's a strain? It's an injury to a muscle or tendon by either overstretching or overuse. So, you know, you decide that you're going to lift a 100-pound box that's on the floor, and you bend over. You're not bending at the knees. You should have bent at the knees, but you didn't. You bent over. You picked up the box, and now suddenly you have acute onset of lower back pain. That's likely a muscle strain. So it's the muscle tendon that's attaching to the bone. Okay, a muscular strain. Okay, how do you treat these? Vast majority are treated with your typical management rest, ice, compression, elevation, and then add after that non-steroidal anti-inflammatories if you're able to tolerate them, right? So ibuprofen, naproxen, some kind of anti-inflammatory. Okay, so let's just briefly talk about joint dislocations. So a joint dislocation is where the articulating surfaces are not in contact anymore. So we could think of the head of the humerus at the shoulder has come out of the glenoid fossa. It's dislocated out. Or the hip joint has dislocated out of the acetabulum. Okay? Joint dislocations need to be put back in rather quickly because when the joint is dislocated, well, the ligaments are all being stretched because it's not back in the joint, so everything's being stretched. And in some cases, such as the hip, the blood supply to the hip comes into the head of the femur, like right at the ball. So when the hip is dislocated, it's potentially lost its blood supply because that's where the artery comes into the femoral head. Okay. Okay, so what about the medical management first of a dislocation? Okay, so someone comes in and their shoulder's dislocated. They were diving off a diving board, and it's a classic way to dislocate, by the way, and their arm hit the water really hard and it swung backwards and they dislocated the shoulder. And by far the most common shoulder dislocation is an anterior shoulder dislocation, meaning the ball of the shoulder has come forward. Okay, you can see the bulge in that image on the right there. That's an anterior shoulder dislocation. Okay, so we need to reduce it. So how do we reduce a dislocation? Well, most people typically need something for the pain, so we usually put an IV in, and they usually need some kind of IV opioid, so often we'll use, say, fentanyl. We need a relaxant. And usually we'll use a benzodiazepine as a relaxant. So diazepam, lorazepam, midazolam, something to relax the body and the muscles. And then once they're sedated and they have some analgesia, we can then put the joint back into place, right? And then we immobilize it with a sling. Okay, so after the joint's back in place, or even before the joint's back in place, we need to make sure, so there's what's called the 6 P's of neurovascular function. Okay, so those 6 P's are really important. So say it's the shoulder, well, we're going to go to the wrist and we're going to check. Do they have a pulse? Okay, if they don't, that dislocation might be impinging an artery. So we need to check for pulselessness. We need to check for pain down the arm, which may be an indication of a blocked artery. We need to check for a pale arm. We need to check for paresthesia, which is pins and needles of the entire arm. We need to check for paralysis. And the last fancy one, poikilothermia, which is cold. Okay, so in order to get to the 6 P's, they had to use some fancy words. So pulselessness, pain, pallor, paresthesia, paralysis, poikilothermia. Those are all indications of either the arteries being blocked and it's losing blood supply to the limb, or there's been a nerve injury. And the nerve injury is causing the paralysis and the paresthesias, the pins and needles. Okay. Complications of a dislocation. So avascular necrosis can occur in a dislocation if the blood supply coming into the joint has been torn away when the bone got dislocated. So the hip is classic for that because the blood supply comes right into the head of the femur, and when the hip gets dislocated, the blood supply gets compromised, and the head of the femur, that ball that you're looking on the right there, can die, and they're left with what's called avascular necrosis and a very misshapen femoral head. Okay, and of course that leads to osteoarthritis, hip replacement because of the avascular necrosis. Okay. Okay, so let's talk about carpal tunnel syndrome in a bit more detail. So this is compression of the median nerve as it goes through the carpal tunnel at the wrist. Okay, so there's a number of risk factors for developing this, but if you were to think about it as anything that increases the pressure um, or occupies some space in the carpal tunnel and potentially puts pressure on the median nerve is going to lead to carpal tunnel syndrome, because that's all it is. It's compression on the medial nerve, right? So what can do that? Well, how about rheumatoid arthritis? Well, if you have rheumatoid arthritis of your wrist, there's more swelling there, and that can cause carpal tunnel syndrome. Diabetes is a risk factor. Not necessarily for reduced circulation, like it's saying in the book, but in diabetes, people can retain fluid. Okay, sometimes their kidneys aren't working as well. They can retain fluid, and some of that fluid can be in the carpal tunnel, and that can lead to carpal tunnel syndrome. Repetitive sports, right? So if or an occupational type issue. So you're a painter and you're constantly brushing, you're flexing and extending your wrist all day long. Well, that's going to lead to a bit of edema in the carpal tunnel area and carpal tunnel syndrome. Sporting injuries. Well, if there's swelling in the carpal tunnel, okay, now you have carpal tunnel syndrome. Hypothyroidism. Okay, so someone who has low thyroid tends to, and we call it myxedema, right? So you're holding on to excessive tissue, you're gaining weight. So that's a risk factor for carpal tunnel syndrome. Okay, so just think of conditions that lead to increased swelling in the carpal tunnel, and then they put pressure on the median nerve. So rheumatoid arthritis, diabetes, hypothyroidism, repetitive occupational injuries, sports injuries, someone who types a lot at a computer, someone who's a cashier, just repetitive use leading to a bit of edema in the carpal tunnel. Okay, expected findings. Well, the first one is typically paresthesia. You have numbness into your hand because the median nerve supplies sensation to part of your thumb, your first finger, your second finger, and half of your ring finger. Okay, so I'm not including the thumb as a finger. So to avoid confusion here, let's call them all digits. So your thumb is the first digit, your index is the second digit. So you have numbness to part of the thumb, your index finger, your middle finger, and half of your ring finger is where you get the paresthesia of carpal tunnel syndrome. Okay. What are some tests that we can do to see if someone's getting intermittent carpal tunnel syndrome? Because often people will come in and say, you know what, my hand goes numb at night, and then I kind of shake it out, and it goes back to normal. And then it comes back again later. Because sometimes people are sleeping with a flexed wrist, right? Okay, and then it leads to a bit of less space in the carpal tunnel, and they get symptoms of carpal tunnel syndrome. Okay, so a lot of it is based on what someone's telling you. Okay, so let's look at some maneuvers here. So we spoke about the paresthesias, which typically come long before the weakness that can come with carpal tunnel. So it's not only a sensory problem, but the median nerve supplies muscles, so they get weaker and weaker over months. But usually people come in a bit sooner about the sensory changes. But if you come in later, you might say, well, I'm dropping my coffee cup. I can't hold a plate anymore. My hand feels weak. And that can be carpal tunnel. Okay? Don't forget, what test do we get for this? Nerve conduction studies, right? Okay, so what's Phelan's test and Tinel's test? So Phelan's test is, so they're both tests for carpal tunnel syndrome. So basically you just ask the patient to put the backs of their hands together, okay? Backs of their hands together and push. And both of their wrists get fully flexed, okay? Fully flexed together, as in the image there. And what happens is you're making less space in the carpal tunnel, and people will start to get the tingling in their thumb and their digits and their fingers, right? Because of that flexion. The other test is Tinel's sign, where you just take your finger and you tap over where the medial nerve is. And the medial nerve is on the median nerve, sorry, is on the outside of your wrist. So it's on the lateral part of your wrist as it's going through. So we just tap. So it's close to the radial artery. Okay, and we just tap there. Okay, and if they say, oh, I have numbness, I can feel numbness starting. Okay, that's a positive Tinel sign. Okay. Now let's look at some treatments for this. What can we do for carpal tunnel syndrome? Well, we can splint them so that they can't bend their wrist. Okay, that's going to help because they're not doing that repetitive flexion and extension with whatever activity they're doing. So that's going to help. We can give them some non-steroidal anti-inflammatories to try and reduce some of the swelling in the carpal tunnel. That's going to help. We can inject a corticosteroid injection into the carpal tunnel, not the nerve, carpal tunnel, to try and reduce any inflammation in there, such as from rheumatoid arthritis. Okay. And lastly, and most effective for sure, is surgery. And all they do is they open up the wrist, Okay, and by the way, this is after nerve conduction studies. No one's going to do um, a carpal tunnel release surgery without proving that it's carpal tunnel syndrome. So they have a nerve conduction study that shows, yes, there's a blocked nerve, blocked median nerve in the wrist, and then they do a surgery called a carpal tunnel release, where you can see the incision in the image there, and they just cut the ligament that's holding the carpal tunnel really tightly together, and it just releases everything inside, okay? And it's usually very effective. Okay, so post-surgical, well, elevation of the hand, good idea, just to reduce the swelling because they just had surgery. Definitely checking the neurovascular status of the hand, the fingers, because they just had surgery around nerves and blood vessels. So, checking the arteries, so the pulse, and checking for sensation of the hand. So that's important, right? Whenever there's arteries or nerves around, we always check to make sure that they haven't been injured. Okay. And then reducing hand flexion and extension and repetitive movements for 4 to 6 weeks, just to allow the whole area to settle down after the surgery. Okay. Okay, so let's look at some fractures and fracture classification. Okay, so what's a fracture? Broken bone. Okay, what's an open fracture? It's punctured through the skin. It's now been exposed to the environment. And whenever bone is exposed to the environment, what's the biggest concern? Infection. Bone was never meant to be exposed to the environment. And if you think about it, bone is kind of a meshwork of matrices and trabecula, and so if it gets bacteria in there, it's really, really hard to treat. Okay, so an open fracture is a fracture that's punctured through the skin, and sometimes it's sneaky because it punctured through the skin and then it went back in. So if we see a laceration or a cut where there's a fracture below, we just assume that it was an open fracture. Okay. A closed fracture is basically any other fracture that hasn't punctured the skin. It hasn't penetrated through the skin. Okay. A displaced, what's a displaced or a non-displaced fracture? Well, a displaced fracture means that the bones just don't line up the way they were anatomically. Okay, they're just not in alignment. So sometimes we have to reduce them and put them back into alignment. And that might be a closed reduction where we can do it just with some analgesia and sedation and we can just adjust it. Or it might need an open reduction where they go in and an orthopedic surgeon will go in and openly reduce the fragments, put them back together, and that often then includes wiring or pins and screws to keep it aligned. Okay. So displaced, bones aren't close together. Non-displaced means, yep, there's a fracture, but the bones are in good alignment. Okay, so let's just do these terms at the top here, and then that's probably going to complete most of them at the bottom anyway. So what's an avulsion fracture? So an avulsion fracture is, say you go over on your ankle. So you go over a sidewalk and you twist your ankle really badly, and you immediately get lateral ankle pain. And you have an x-ray, and instead of the ligament tearing, the ligament actually pulled a little piece of bone off. And that piece of bone we called an avulsion, so an avulsed piece of bone. So the ligament stayed together, but it pulled off a little piece of bone. That's all it means. Okay. And it can happen at the elbow, so the epicondyle. It can happen at the ankle. It can happen anywhere. So just know the term avulsion. Comminuted means that there's more than 2 fragments, right? So if there's a fracture, then you would think, well, I have one piece of bone and the other piece of bone. They're fractured into 2. Okay. A comminuted fracture is more than 2 fragments. So if, say, a bone is crushed, well, it's probably multiple pieces of fragments within the fracture, right? That's comminuted. A green stick fracture occurs in children, and it's a fracture that really only occurs on one side, but it doesn't really go right through to the other side like it would in an adult. Okay, children have much softer bones, and sometimes they just bend and fracture one side, but the other side stays intact. Okay, what's an impacted fracture? Well, it's basically just a fracture that's kind of just been impacted within itself. So, you know, I'll give you an example. If I was to just step on a Coke can and just compress it a bit, just squash it down, that's what an impacted fracture is. It's just been kind of, I fell really hard, say on my wrist, and I squashed the bone into itself. It's wedged inside um, uh, the fracture. Okay. An oblique fracture just means that the fracture isn't going straight across the bone, it's going at an angle, so usually diagonal. A spiral fracture typically looks like an oblique fracture, and it's usually from a twisting motion where the bone fractures because of all the force, and we call it a spiral fracture. Transverse fracture is just a straight line right across. Okay, so let's look at the images. Okay, the first one has no fracture. The second one is just basically a simple transverse fracture. The third one, the oblique one, so you can see it, the fracture's on a diagonal there. So that tends to make the fracture a bit more unstable, right? You can see that the top bone can slide against the lower one. A spiral fracture is a twisting motion that results in a fracture, and often they look like oblique fractures. Comminuted fracture means there's more than two fragments. Okay, there's a whole bunch of fragments. A avulsion fracture is where instead of the ligament tearing, it just took a piece of bone with it. Impacted fracture just means that the bone's been kind of squashed into itself due to a fracture. A fissure, I have no idea what a fissure is. Fissure is just basically, I usually think of an anal fissure where there's been a tear in the anal canal and there's bleeding from it. I don't use the term fissure in bones very often. A green stick fracture, again, that's in children where one side has been fractured, but because their bones are a bit flexible, it didn't really just break right through and snap off like a twig. Okay, so that's why we call it a green stick fracture, because green sticks on trees, they bend a bit. Whereas once you become an adult, you're not as flexible anymore, and when you have an injury with enough force to fracture, you just fracture right through. Okay. Okay, so this slide, usually I'll do some questions. So now some of these questions we actually haven't covered yet. So let's just do them. They're at the back of chapter. They're at the back of chapter. Well, the trauma chapter. So whatever. That is chapter 71. Okay. So a nurse is teaching a client how to manage an external fixation device. So that's a device that's put in by orthopedics, and it comes through the skin, and the metal device is holding the unstable bones together. So an external fixator. Okay. So the nurse is teaching how to manage this external fixation device upon discharge. Which of the following statements by the client indicates an understanding? I will clean the pins more often if drainage from the pins increases. Okay, that makes perfect sense, right? Just to stop all the crusting and discharge around the pins. I will use a separate cotton swab for each pin. Good idea. Otherwise, if one pin's infected and there's discharge around it, then you're taking the cotton swab and using it on other ones. So that's a good idea. I will report loosening of the pins to my doctor. Definitely, if you notice that the pins are loose, well, they're probably not providing much support. So if something's happened with the loosening of the pins, that needs to be reported. I will move my leg by lifting the device in the middle. Yeah, that's not a good idea, right? You shouldn't be using the external fixator as a way of moving your leg, okay? Because that could injure um, the fractured bone. So I will move my leg by lifting the device. No, don't do that. A report increased redness at the pin sites. Definitely, right? This has gone through bones. It's fixating bones. And if there's redness or swelling or more pain at the pin sites, that's an indication of potential infection. That needs reporting. So A, B, and E. A nurse is assessing a client who has a casted compound fracture of the femur. Okay, so it's casted, and it was a compound fracture, meaning it went through the skin. Okay, I already think that's at risk for infection. Okay, compound fracture. Which of the following findings is a manifestation of a fat embolus? Okay, so they're asking a different question here. Okay, so a fat embolus is where when you have a fracture, bone marrow is leaking into the bloodstream, typically in the first 24 to 48 hours, and that fat from the bone marrow is traveling to the lungs and causing certain symptoms. Okay, so which of the following findings is a manifestation of a fat embolus? Altered mental status, definitely. So the three ones you should remember for fat embolism is onset of shortness of breath because it's fat globules going to the lungs. Petechiae, those little blood spots on the upper chest and neck area, because those fat globules are going into the little capillaries and blocking them off, and they're breaking open. And lastly, the fat globules can travel to the brain and cause confusion. So altered mental status is definitely one of them. Reduced bowel sounds, no. Swelling of the toes distal to the injury, no. Pain with passive movement of the foot distal to the injury, no. None of those are signs of fat embolism, so it's A. 3. A nurse is assessing a client who's had external fixation device applied 2 hours ago for a fracture of the left tibia and fibula. Which of the following findings is a manifestation of compartment syndrome? Okay, so compartment syndrome is when there's increasing pressure in one of the muscular compartments, because muscles are separated from each other by this very thick fascial layer. So if edema or bleeding or anything increases the pressure in a compartment, that can lead to compression of arteries. So that's going to lead to ischemia down distal to the compartment, so say the foot. And it's going to also compress the nerves, and that can lead to death of the nerves. Okay, so let's look at what it could be here. This is a selectol. Okay, intense pain when the client's left foot is passively moved. So if you move the patient's foot up and down, what are you doing? You're stretching the muscles within the compartments. And if muscles are basically dying because of the high pressure, that's intensely painful. So A is correct. B, capillary refill of 3 seconds on the client's left toes. No, a refill of 3 seconds is fine. So if it was a capillary refill of 7 or 8 or 9 seconds, that means, the artery supplying the foot and the toes is being compromised, and that's why the capillary refill is so prolonged. Hard swollen muscle in the client's leg, absolutely. That's the compartment syndrome under high pressure. Burning and tingling of the client's foot, absolutely. That's the nerve that's starting to die and be at least being compressed in the compartment. Client report of minimal pain relief following a second dose of opioid. Yes, that's one of the classic findings of compartment syndrome, that someone's pain is unremittingly getting worse. They cannot control it with pain medication. So we always tell patients, if your hand goes cold, if your hand, say it's a fracture of the arm, if your hand goes cold, if your hand goes numb, you need to return. If you have intense pain under the cast, you need to return. Okay, so any of those things. Now, in this case, there isn't a cast. You don't need to have a cast to get compartment syndrome. If you have a significant amount of damage or injury, you can get enough edema in the compartment all by itself and develop compartment syndrome. Okay, so the answer is A, C, D, and E. Okay. 4. A nurse is completing discharge teaching to a client who had a wound debridement for osteomyelitis. Okay, osteomyelitis, that's infection of the bone, and they had a debridement, meaning they got cleaned up a bit, and some of the dead bone was removed, and the wound was cleaned up. Which of the following information should the nurse include? Antibiotic therapy should be continued for 3 months. So osteomyelitis, you're often on antibiotics for a long, long time. It's not always 3 months, but it's typically 2 to 3 months. Okay, so somewhere in that range. It's not fixed at 3 months, but it's a long time, and often it's on IV antibiotics first, followed by oral antibiotics once it's starting to settle down. So it's a really long time. Which of the following information should the nurse include? Relief of pain indicates the infection is eradicated. Absolutely not. It can stay for, as I said, months and months and sometimes years. Airborne precautions are used during wound care. I'm not really sure why airborne precautions would be used. Contact precautions would be used to prevent the spread from, say, person to person. Or it's not an airborne issue at all. Expect paresthesia distal to the wound. No, you should not expect paresthesias distal to the wound. In fact, onset of paresthesias means that there's a nerve being impacted now, and that should be reported. So the answer here is A, that antibiotics will likely continue for 3 months. Okay. 5, a nurse in the emergency department is planning care for a client who has a right hip fracture. Which of the following immobilization devices should the nurse anticipate in the plan of care? Skeletal traction, Buck's traction, Halo's traction, Bryant's traction. Okay. Well, it's going to be Buck's traction. Okay. It's just a device that we can use to immobilize the fracture and just put some traction on the leg to reduce the spasms that occur with the fracture. Okay. Halo traction is for a neck fracture. Bryant's traction is for congenital hip dislocations. And skeletal traction, that's more for someone who is lying in bed and receiving immobilization and traction for a femur fracture. So a long bone femur fracture, not a hip fracture, which is the proximal femur. Okay. Okay, so let's just look at some images here. So the first image is of an elbow. Well, the first image is showing you the photo, and as I mentioned, so there's an open wound there, and whenever we see an open wound with a fracture below it, we suspect it's an open fracture, right? Or another term for it is a compound fracture. Okay, so that's a displaced fracture, so it's not in line at all. So we would call it a displaced compound fracture of the elbow. Okay. Let's look at the second one, which is a toe fracture. We're not going to do anything for that, by the way. That's just going to heal by itself. Sometimes we don't even x-ray these, right? So if it hasn't gone to the skin, we're not going to call it an open fracture, and likely it hasn't. So it's going to be a closed, undisplaced or non-displaced fracture of the second toe. Okay. The third one is Open or closed, I can't tell from this image if it's gone through the skin. If it's gone through the skin, it'll be an open fracture. If it hasn't, it'll be a closed fracture. Is it displaced? Yes, it's displaced for sure. Okay, that tibia should be right together. And then we would just call it a transverse fracture or oblique fracture. But this is a displaced fracture, and it looks like there's multiple pieces, so it's comminuted. So it's likely closed. Probably didn't go through the skin. Is it displaced? Yes. So it's a closed, displaced, comminuted fracture. Okay, so I think this slide. By the way, I often say this. I'm not going to spend much time on it, but I'm going to try not to, because really this slide is just giving you risk factors for musculoskeletal trauma. Okay, so sure, if you have osteoporosis, you're at higher risk of fractures. Of course, if you're having frequent falls, higher risk of fractures. A motor vehicle accident, substance use puts you at higher risk because you're intoxicated. Bone diseases, whether it's a bone cancer, osteoporosis, Paget's disease of the bone, will make you more prone to fractures, and so on. Okay. Expected findings of musculoskeletal trauma, in particular a fracture, well, definitely pain, decreased range of motion or decreased use of the limb, if it's a limb, crepitus at the site, meaning you can feel that crunching movement if the limb is moved or the fracture is moved. Deformities, right? If it's a displaced fracture, it's going to have a deformity. Muscle spasms around the fracture. Muscles go into spasm because they're trying to hold the fracture tight. So muscles go into spasm to try and protect the fracture. Edema at the site, and then bruising, ecchymosis. Okay. Diagnostics. Most fractures are diagnosed with an X-ray. Some, if they're really not seen on X-ray and we still suspect them, then we can go on to either a CAT scan, an MRI in certain circumstances, or a bone scan. A bone scan just takes longer, right? I mean, it's a very good test. It just takes longer. You have to go and have the dye injected, and then go away for 2 or 3 hours, return, and then have the bone scan. So it's just a longer process sometimes. Okay, so let's just talk about some general interventions for musculoskeletal trauma. Okay, so the first one, no matter what someone is coming in with, when we're talking about a trauma, it always goes back to ABC, okay? Airway, breathing, and circulation. And in fact, in a bit more detail, it's airway with C-spine stabilization. So we always have to remember that the C-spine can be injured. So you can think of it as A with a little C above it, airway with C-spine stabilization, breathing, circulation. Okay. Frequent monitoring of vital signs, because we never know what other injuries have occurred. Even when someone comes in with a fractured leg from a motor vehicle accident, they may have a ruptured spleen. They may have a liver laceration. They may have something else going on, so we monitor vital signs frequently. Neurological status, well, anyone who has a head injury, we're going to do frequent neurological examinations, and they can be just very straightforward. What's your name? Where are you right now? Where do you live? Do you know what time of day it is? Just very basic things to see if they're fully alert, right? And they have a GCS of like a full GCS of 15. Okay. Now, if we're happy with the ABCs, the vital signs are all good, neurological status, we're all happy with that. Stabilizing the injured area. So say it's a femur fracture or a tibia fracture, we want to stabilize the fracture, right? Otherwise it's moving and the patient has more pain because of the movement. Okay. Some fractures may need to be reduced, meaning they're quite angulated or they're quite displaced, and we're going to reduce them to try and get them back into a proper position. And that would go for a dislocation of a joint, okay, that's not a fracture, and a displaced fracture. We'll try and get the alignment close. Okay. Once we've immobilized it, elevation. So to elevate the limb, in particular the lower limb or the upper limb, above the level of the heart, allows for more drainage. So it's going to reduce the edema. Okay. Application of ice, again, will reduce edema. Always keeping in mind to assess for bleeding. Okay, so if there's an open wound, they can bleed quite a bit, especially something like a femur fracture. If it's open, or even if it's not open, femur fractures can bleed a lot, even into the thigh. Okay, so assessing for bleeding, applying pressure to bleeding sites, covering open wounds. So in terms of covering an open wound where you think a bone has come through, it's just to cover it to keep it clean, right? So sometimes we'll just use dry dressings just to cover it and protect it. Removing clothing and jewelry near fractures. Typically in a trauma, we're going to remove all clothing, so because in the end we're going to do a head-to-toe examination, right? So we typically remove all clothing and jewelry to do a full exam, making sure that the patient is warm. So let's just go back up to A, B, C. So it's actually A, B, C, D, E is what we use. Airway, breathing, circulation, neurological status is D. D stands for disability. So that's neurostatus. So we do a quick neurostatus. And E is environment. And one of the things in E is making sure that the environment is warm for the patient. Okay? That's really important. Otherwise, they get cold very quickly. Frequent neurovascular checks. So if it's a fractured femur, we're going to check the pulses of the foot and the ankle, right? The dorsalis pedis and the posterior tibial artery. And we're going to check for sensation of the foot, right? Do they have pins and needles? Can they feel us pressing their toes? So those are neurovascular checks. And we do them before any surgery. We do it after they've had surgery or they've had casting or fixation of the fracture. Okay, really important. Medications. Well, medications typically center around analgesics because fractures are painful. And for the most part, initially, it's opioid analgesics, which, don't forget, opioids are very constipating. So typically, patients will need stool softeners in the coming few days. Okay. Non-opioids, acetaminophen is also used because we try to get people off the opioids as the days go on and continue with acetaminophen. Just because the opioids, we don't want people to be on them for weeks and weeks if it's not required. Non-steroidal anti-inflammatories are also important for these injuries. They reduce the inflammation. Always remember, non-steroidal anti-inflammatories, what are the adverse effects? Gastrointestinal. They harm the kidneys. They elevate blood pressure. They can aggravate congestive heart failure. Okay, just in general, non-steroidal anti-inflammatories. Muscle relaxants can be used if there's a lot of spasming around the fracture. Okay. Prophylactic antibiotics, if someone has an open fracture, meaning it's punctured through the skin, we definitely give antibiotics. Okay. Because there is such a high risk of developing osteomyelitis. For a closed fracture, and there's no bone sticking through the skin, no, we don't use antibiotics. Okay. And I think that's it for this slide. Let's go on. Okay, so this is just showing some different immobilizing techniques. And we'll talk about some of these in the coming slides. So splints and immobilizers, okay, we'll take a look at those. Casts, so casts can be from plaster of Paris or fiberglass, and we'll talk a bit about that. Traction, so traction is typically for an upper or lower limb fracture for the most part, and you want to apply traction to keep the bones pulled apart, to keep them in line, okay? External fixation is where a fractured bone is stabilized and then there's outer hardware. So say someone has a femur fracture and they put rods through it externally, okay? So they puncture through the tissue, through the bone, and it comes out the other side, and then they fixate the whole, all the pins to an external device, okay? Internal fixation is where they open up the fracture, they open up the tissue, go to the fracture, and put either a plate or pins or screws inside, okay? And sometimes those are left in permanently, and other times they're removed later on, like months to years later. Closed reduction is where there's a displaced fracture and we think we can get it into normal alignment by just manipulating it from the outside. So by pulling and turning it in certain ways, we can get the fracture back into a good position. That's closed reduction. Okay, so closed reductions are frequently done in the emergency room. For wrist fractures, for lower leg fractures, we can try and do a closed reduction. And of course, when we're pulling on someone's leg or arm to get the bones back into a good position, they need sedation and they need analgesia. Okay. Open reduction, well, so that's where the surgeon will go in, open up the area that's fractured, and realign it while the wound is open. Okay. And typically, if someone's doing open reduction, they're then going to have to fixate it with internal fixation, so screws or pins while they're in there. Okay. Okay, so here's some splints and immobilizers, and they're very easy to use. We typically use them more for ligamentous injuries of, say, the wrist or the knee, compared to fractures, usually. And I'll tell you why. If we really want to immobilize a fracture for 6 weeks or 8 weeks, casting is usually the way to go because there's just no ability to remove it. Okay? There's some downsides to that, but we know that it's going to be immobilized in a good position for 6 to 8 weeks. Okay, so the advantage of a splint, though, is that it's removable, so we can have a look at the skin. The patient can keep an eye on the skin. It can be adjusted for swelling. So as the limb gets swollen, they can release the pressure a bit. Okay, so there's really no risk of compartment syndrome from the splint itself, usually, unless they left it on too tight. But usually, even if someone's wearing a splint, say we immobilize it initially with a splint because there's so much swelling, and then we're going to ask them to come back in 3 or 4 days and convert it to a cast once the swelling goes down. If we put a cast on right from the start when there's lots of swelling to, say, an ankle fracture, it's just loose in 3 or 4 days. So sometimes we'll just immobilize it with a splint and then have them come back for a cast. Okay. So they're easy to use. They're ready-made, and we just choose small, medium, large, and apply the splint for some immobilization. Okay, so I would think of those typically more for ligamentous and tendon injuries around a joint. Okay, so casts. So as I mentioned, most casts are made of either plaster of Paris, which where do you see it here? I think the first image, the high heel, that's plaster of Paris. That's your typical casting material. But fiberglass, so the upper image, the pink, is fiberglass there. It's super strong and super light. Okay, so fiberglass can be used, and we can use plastic casts, right? So air casts, which is the image on the middle left. Air casts can be used for foot fractures, ankle fractures, and they're light, they're removable for bathing, they're adjustable in terms of how tight we want them, so they can be very useful. So typically for a cast, what we do is the, the, the first part is, say we have someone with a wrist fracture that we want to put a cast on. So we'll cut a length of stockinette, so a cotton material. It looks a bit more substantial than the lower image here. So it's a stockinette that goes over the wrist area and the forearm. And then we're going to roll on some, just some cotton padding that we roll on the area, and then we apply the cast, okay? And casts take, even though they feel hard in about an hour, they can take about 24 hours to really harden up, okay? So where do we typically put casts? So we can have short arm casts like you're seeing at the lower image here, well, the beginning of it anyways. We can have long arm casts, say for an elbow fracture. We can have short lower leg casts for an ankle fracture, or long leg casts for, say, a tibia fracture. Okay, so all kinds of options. What are the most important aspects when someone has a cast on? Neurovascular status beyond the cast. Always think that if someone has a cast on, they're at risk of developing compartment syndrome. Okay, so the cast has become too tight. So we always want to check the fingers. Okay, can you feel me touching your fingers? Are they numb? Are they really swollen? Is there incredible pain below the cast? When I press on your fingers, is there good capillary refill? Okay, does the blood return very quickly within 2 to 3 seconds? Or does it take 8 or 9 seconds for the blood to return? Okay, so we'll talk about that complication a bit more. Okay. So I would say for the most part, people choose fiberglass casts. I wouldn't say it's a wrist fracture or a leg fracture, but I'm going to tell you a lot of the time for leg fractures, we can sometimes use a walking air cast or a walking air boot, and those are really comfortable, right? You can see the image there. You can Velcro it on, and then there's ports to pump in some air to really make it nice and firm and still comfortable. Okay. Plaster of Paris is just as good. It just happens to be heavier, and also you can't get it wet. If you get it wet, it just starts to fall apart and become mush. Okay. Fiberglass is a bit more tolerant to moisture. So even if a bit of water gets onto it, it's still going to be fine. Okay. Okay, so some information for a patient with a cast. So definitely don't start poking around in there. You're just going to disturb the initial stockinette that was put on, that cotton stockinette, and you're going to move around the roll of cotton that was put on, and then it's going to become more irritated. And you can actually poke into the skin, right? And then you might have a skin infection. So not to put anything down into the cast. So people will use a hair dryer to allow air to go in there if they're really itchy. We tell them to return if the cast becomes very painful. And some people say, well, the fracture already hurts. And what we say is, yes, the fracture hurts. It's going to feel much better in the cast because it's not moving around anymore. But if it were to become incredibly painful, much more than it is right now, then you need to return because you may be developing compartment syndrome. Okay. Often, well, plaster Paris casts are not waterproof, and many of the fiberglass casts are not waterproof, right? So if you take a shower with a short arm cast, the water is just going to pour in the top. So, and it's just going to make a mess of the cotton inside. Okay, so you need to cover that with a plastic if you're taking a shower or a bath. Okay, so reporting pain. So if it's severe pain, we think of compartment syndrome. If there's one particular area of the cast that's really bothersome, it might be a pressure point where the cast was just put on either a bit too tight or it's rubbing in there, and it might be an area that's starting to develop some skin breakdown. Okay. Reporting shortness of breath is really that thought that, okay, in the first 1 to 3 days of a significant fracture, say a femur fracture, you can develop a fat embolism. But the other thought is that leg's going to be immobilized for weeks. So if you were to get shortness of breath or chest pain weeks out, so sudden onset of chest pain and shortness of breath, we might start thinking, could this be a pulmonary embolus? Okay, so that's where reporting of a shortness of breath comes in. Okay, I'll just briefly talk about traction. I think it's well covered in the book. On the left, you can see different types of traction. So there's a Buck's splint and traction, Bryant's splint and traction, and skeletal. Okay, and what's the concept of traction? Well, it's providing a force to maintain alignment, right? And I'm going to tell you, traction was much more popular years ago, where you could walk down an orthopedic ward and there'd be people in traction all over the place for different fractures. Whereas now, internal fixation, where the surgeon goes in, puts rods or screws and plates, tends to be used more commonly because it gets the patient up faster and they can mobilize, so it prevents complications, okay, like DVTs. Okay, so what's the goal? Well, to prevent soft tissue injury when we're talking about traction, right? So the force is making sure that the skin is not squashed against each other because of the displaced fracture. So it's when the bone is nice and straight, the tissue's gone back to normal. Realignment of the bone fragments, decrease in muscle spasms because the traction has made the fracture nice and straight. It's not twisted or angulated anymore, right? So that's the idea of traction. The other thing about traction is that you can imagine if someone's leg is deviated and displaced, well, the arteries and nerves that are going down the leg are going to be displaced and deviated as well. So when you apply traction, if there was any concern about the pulses or the nerves, they're much safer when the patient's in traction because they're not being injured by some displaced fracture. Okay, so traction is also important to protect the blood vessels and the nerves from injury. Okay, the types of traction, well, there's traction that's right from the skin. And you can see a couple of examples there, Buck's traction and Bryant's traction. And then there's skeletal traction, which requires pins or wires that are put through the bone, and then the traction is applied from there. Okay, so I'm not going to spend too much time on this. It's in the book. Okay, we'll continue on. Okay, I think this is well covered in the book too, so we're just seeing someone in traction here. Remember, any pulses distal to the fracture is what we're going to check for the neurovascular status, right? So we want to check the nerves. Well, in this person, we'd want to check the nerves and the blood vessels at the most distal part of the injury. So we're going to be checking the foot and the ankle pulses and we're going to be checking that they have sensation to the toes and that they can move their foot. Okay, so neurological is sensory and motor, and then of course checking the pulses and the color of the foot, the warmth of the foot. Okay, so really important. Maintaining body alignment is important with traction, of course. I think I'll leave the rest just to you because I know this is in the book. Assessing the pins for infection, if there's pins in. So drainage, redness, any loosening of the pins. Cleaning of the pins when they are cleaned. We don't use one Q-tip for multiple pins in case there's cross-contamination. So one Q-tip gets used for each pin. Okay. Okay, let's move on. Okay, so here's external fixation. So you can see there's a lot of hardware to an external fixator, right? So there's pins or wires that have gone into the bone, and then there's this external fixation device that can be adjusted that the patient now has to carry around with them, or just have until the bone heals, right? So you can see one on the lower limb there, and you can see an external fixator for a neck fracture in the lower image. Okay. So when are external fixators used? Again, I'm going to mention that they're used less commonly now compared to internal fixation. Okay. Okay. So when are these used? Well, a really badly comminuted fracture with multiple fragments. Okay, just crushed bone in there. They could use an external fixator. Correcting congenital defects. So let's just say that, oh, there it is, lengthened limbs. So let's say someone has a shorter limb than the other, say a leg. Well, they can actually fracture the limb purposely, and they can lengthen it and then put an external fixator on and let it heal that way to gradually lengthen the limb. Okay. Treating non-union, meaning the bone didn't gel back together with the usual procedure, such as a casting, for 6 to 8 weeks. So now they're going to give it much more time and put pins through, apply an external fixator, and hope that by leaving this in place for many, many weeks, the bone will finally heal. Because some bones don't heal, and we call that non-union. Okay. Same things are going to apply with an external fixator. Neurovascular status. Okay, so I'm starting to sound very repetitive here. That's really important. Elevating the extremity, of course, for edema, so above the level of the heart is important. Pin care, looking for redness, swelling, discharge, and also cleansing of the pins with individual Q-tips, and aseptic cleansing, right? So, cleaning the sites, because remember, these pins have gone through bones, and then they've punctured through the skin again. So we certainly want to keep them clean and prevent infection. Okay, so I don't have any questions for this this part, so I'm just going to move on. Okay, so musculoskeletal complications. I'm sure many of you have heard of these. So avascular necrosis. We're going to talk about that. Just briefly, what is it? Well, it's death of bone because of loss of blood supply to that bone. Okay, so there's certain injuries such as a dislocated hip. There's actually a bone in your wrist called the scaphoid bone, and if that's fractured, there's a risk of avascular necrosis of the scaphoid bone, and part of the bone dies, and people are left with chronic wrist pain. Okay, and the same can happen to the hip. If the hip dislocates, the blood supply is disrupted, and the head of the femur, the ball there, can undergo avascular necrosis, and it becomes very deformed. Okay. Venous thromboembolism, so development of DVTs, and then the risk of part of the DVT breaking off and becoming a pulmonary embolus. Compartment syndrome, where the pressures in a muscular compartment are going up and not only crushing the muscle, but damaging the nerves and leading to particular symptoms and compressing the arteries that are within the compartment and leading to particular symptoms that we'll talk about. Okay, so remember, compartment syndrome can happen from the inside if there's massive amounts of bleeding or edema within the compartment, or it can happen from the outside, say with a really tight dressing or with a cast that has become too tight because the swelling continued underneath the cast. Okay, or the cast was just put on too tight. A fat embolism is where bone marrow and fat leave the fracture site and travel into the bloodstream and deposit in the lungs, in the brain, in the skin, and we'll talk about that. And finally, osteomyelitis is a bone infection. What's the most common way of getting osteomyelitis? A compound or open fracture, right? Compound and open are the same term. So the bone has been exposed to the environment and has become contaminated, and osteomyelitis has occurred. Sometimes, much less commonly, you can get osteomyelitis by having had a blood infection with bacteria that have then seeded the bone and developed osteomyelitis. That's much less common than getting osteomyelitis as a complication of a compound fracture. Okay, so let's talk about compartment syndrome. I've already mentioned it on other slides, but basically it's increased pressure that's occurred within the compartment. And if you look at the lower image there, those are cross sections of different muscle groups, whether they're in the leg or the arm. And notice how the muscle groups are separated by these fascial linings. And they're in separate compartments. So if there's an injury, whether it's a fracture or a crush injury or incredible amounts of edema within one of these compartments, the pressure builds and builds and builds until the muscle starts to die because of ischemia. The blood supply distal to the compartment, so the arteries start to be compressed, and also the nerves start to die because of all the pressure within the compartment. Okay, so now compartment syndromes do not need to be only from a fracture. As I said, they can be from a crush injury. They can be from anything that's caused increased pressure within the compartment. Okay, so a cast can do it. A very tight wrapping that's not allowing for expansion when edema occurs can cause it. So it can be from an internal problem like bleeding or edema within the compartment, or something external like a very tight wrapping or a cast. Okay, so definitely this is a serious complication of casting, but it doesn't need to be from casting only. And once it develops, the tissue, meaning the muscle, can start to die in the next 4 to 6 hours, right? So it's pretty urgent to do something about compartment syndrome. So what are the symptoms? Well, typically someone will come in and they'll have pain out of proportion to what you would expect. And if you were to feel the compartment, say it's in the calf, it would be rock solid. It would be really, really hard. Okay. And again, say there's a compartment syndrome in the calf, in a calf muscle compartment. If we were to move the ankle, so we would flex and extend the ankle, that would cause significantly more pain because we're actually stretching the dying muscle within the compartment. Okay? And remember those 6 P's, right? Remember what happens to the limb distal to the compartment syndrome. the pulselessness, um, well, the pain out of proportion at the compartment site. So you lose your pulses, distal to the compartment syndrome. You'll have pale looking skin because the arteries being compressed. You'll have a cold limb, so poikilothermia or cold limb. You'll start to lose sensation, so you might have pins and needles at the beginning, but that'll progress to loss of sensation. You'll have paralysis because the muscle's dying, so it won't be able to move the limb anymore. So remember those 6 P's, okay? So what do we do? Well, depends what's causing the compartment syndrome. If it's a cast, then we'll cut open the cast and relieve the pressure. So a cast or some kind of tight dressing. If it's a compartment syndrome because there was so much swelling or bleeding within the compartment, then it needs to be opened, such as you see in this image here. Okay, and that's called a fasciotomy, where a surgeon will open the compartment, or a healthcare provider will open the compartment emergently to release that pressure. Okay, and then typically it's just lightly packed, and the compartment is left open until the swelling and the pressure settles down. Okay. So again, big thing for compartment syndrome, the 6 P's, which is the neurovascular status, right? What are the nerves doing beyond the compartment syndrome? Is the patient complaining of numbness, pins and needles, loss of sensation? Are they unable to move their limb anymore because the muscle's dying? So that's the neural part. The vascular. Can I feel pulses? Does it look like a pale limb? Is it a cold limb? So all of those things are the vascular side of it. Okay, so this is an emergency. This has to be addressed right now. Okay, so a fat embolus, well, this is from a fracture. Okay, so I just mentioned that compartment syndrome doesn't need to be from a fracture only. Fat embolism, they're from fractures, and typically a long bone, such as the femur or the tibia. And when it fractures, it releases the marrow, which is made up of lots of fat, into the bloodstream. And that travels to the circulation and goes to the lungs. Okay? And when it goes to the lungs, typically in 12, 24, 36 hours, you start with shortness of breath, so dyspnea. Okay? And at the beginning, it's hard to tell, well, why is this person short of breath? But it's one of the things we need to think of following a long bone fracture. Okay? What else do they develop? So those fat globules can get to the brain, and it can lead to agitation, restlessness, confusion. Encephalopathy just means that the brain is not working normally. So all of those types of symptoms of confusion, restlessness, agitation. It can also, those fat globules can block up little capillaries in the skin, and those capillaries break open, leading to petechiae, typically on the upper chest, the neck. So a petechial rash is forming. Okay, so those are the 3 main ones: shortness of breath, neurological symptoms, and petechial rash. Okay, so how do we diagnose this? Well, it's definitely that you have to think of it, right? There's no one test that's going to tell you this person has just had a fat embolus. Okay? So how do we prevent it? Well, if we can immobilize the fracture, say in a splint or a cast or traction, well, it's going to bring the bones back together, and it's going to stop them from moving against each other. And that's going to prevent more fat from going into the circulation. So just minimizing the movement and manipulation of say, a femur fracture is going to help prevent more fat going into the circulation. Okay? Early surgical intervention to repair the fracture. So you can imagine if you have a displaced fracture, there's marrow that's leaking out into the bloodstream. So early surgical repair, say internal fixation, to bring the bones back together, okay, and stop the leakage of the fat into the bloodstream. Okay, patients often need oxygen because they're hypoxic or hypoxemic. So they may require oxygen because of their their dyspnea, right? And the last bullet point here, adequate support for fracture during repositioning. Well, that makes sense because if you're moving someone with a fracture, well, that fracture is going to be manipulated potentially and move and release more bone marrow. Okay. Okay, we're almost there. I know this one's been a bit long, but there's lots of information. So the last complication, osteomyelitis, which is typically a bacterial infection of the bone. Okay, and what's the most common cause of it? An open fracture. So what kind of symptoms is someone going to develop from osteomyelitis? Well, typically we know someone's at risk for osteomyelitis because they've had a compound fracture and the bone has gone through the skin. So even if the bone poked through the skin and went back in, we know it's had exposure to the environment and they're at risk for osteomyelitis. So what can develop? Well, you can get more and more pain and swelling at the fracture site because there's infection there, right? So it's not settling down. And typically, a fracture will settle down over days to weeks. You can form connections between the osteomyelitis, the bone infection, and the surface of the skin, and have drainage. As you can see in this image here, you can have discharge of purulent drainage from the bacterial infection. Okay. The bacteria can then go into the blood supply. So not only is it draining onto the skin, it's also going into the blood supply and causing sepsis, right? So fevers, hypotension, tachycardia, so they're septic, right? The non-healing ulcers, and what I just mentioned, because of the infection, is chronically discharging pus to the surface. And the x-rays will start to look abnormal because the normal bone is being destroyed, right? So at the beginning, osteomyelitis does not show on an x-ray. So for days to weeks, x-rays do not show osteomyelitis. It's only when the bone starts to be destroyed that osteomyelitis now shows up on x-ray. Okay, so doing an x-ray right away or in a day or two, it won't help us diagnose osteomyelitis. Okay. So we may have to do a bone scan. A bone scan would definitely pick this up. It would light up the area of the osteomyelitis. An MRI or a CAT scan would definitely alert us to potential osteomyelitis. What about other tests? So in terms of blood work, well, typically, because you have a bacterial infection, your white blood cell will be elevated, and in particular, your neutrophils. The ESR, which is erythrocyte sedimentation rate, it's a marker of inflammation, that'll be elevated. Okay? So we use those inflammation markers such as ESR and CRP to help us, to alert us that there's potential osteomyelitis and an elevated white blood cell count. Now, we can also take wound cultures, so we can dab that wound that we're seeing in this image and send it off for a culture to see what's growing. We can also take blood cultures to see if there's any bacteria that are growing within the bloodstream. As I mentioned, the imaging, x-rays, sure, typically it takes weeks for changes to occur on an x-ray. MRI would definitely show it, and a bone scan would definitely show it. What's the treatment for osteomyelitis? Typically, it's 2 to 3 months of antibiotics. It's a long time because it takes that long to try to destroy the bacteria that's all throughout the bone. Okay, very hard area to treat. And typically, it's IV antibiotics at the beginning. And once we see that it's settling down, a patient can be converted to oral antibiotics. Okay, but some patients go home with PICC lines and they receive IV antibiotics for months. Surgical debridement, where they're going to open up that wound you're seeing there on the left in the image, open it up, clean it out, take away the dead bone that's never going to recover. Okay. Hyperbaric oxygen chambers are where, there's chambers that patients can go into and pressurized oxygen, and that's been shown to improve oxygenation of the tissue and help with the healing of the wound. Okay. Antibiotic beads are just another way of getting antibiotics into the bone. They can plant seeds that are impregnated with antibiotics and put them into the bone. And finally, if it's a chronic osteomyelitis, not healing, antibiotics aren't working, recurrent debridements aren't working, then amputation may be necessary. Okay. So in terms of nursing actions, it's always going to be the same thing. Neurovascular assessment distal to the wound. Do they have pulses? Do they have a normal neurological status distal to the wound? And of course, dressing changes, right? These tend to discharge a lot of purulent material, and so patients need frequent dressing changes. Okay. Okay, so that's the end of the module. If there's any questions or concerns, you can contact me. It's Dr. Karagesian, or contact your instructor. I hope this was helpful. I know it's on the long side. I skipped some things because they concentrated more on them in the textbook, but I think between the textbook and these slides with voiceover, it'll give you a really strong background for musculoskeletal trauma and the other conditions that we spoke about. Okay, see you at another module. Bye-bye.